Hi friends. So now we're going to be talking about PSM. It is one of the subjects where it could be either ways. Sometimes they give you very predictable questions, but sometimes it's just crazy. So what you have to remember is if they go crazy, particularly in NICT, it's going to be crazy for everyone, right? So we got to focus on the most important parts and just master that. And this is a subject that you can keep working on. There is a lot of information, there are a lot of updates, and it's worth it in this subject to go after the updates, because sometimes especially NICT will pick up one odd update and ask you. So try to supplement this with as many sources as possible. Try to add on information onto your BTR. So this is a subject where how much ever effort you put in, it's going to be directly proportional in the result, right? So that's something which is very important for PSM. We're going to start off with the good PSM, which is concept of health, epidemiology, biostats, which I consider good. And then we are going to be talking about the not so good PSM, which is going to be vaccines and immunization. So that's very important. Everything about vaccines we are going to be doing here. Then everything about TB and HIV. Then the other programs, health education, health communication, environment, nutrition, everything else towards the latter half, right? All miscellaneous stuff towards the latter half. So that's how we're going to go. So let's begin first with the concept of health. It's a very important image, pretty basic, but what they can do is hide these hide these labels and give them A, B, C, D, and they can ask you to describe it. So look at this. Let's say that there is any organism, right? Let's consider measles. So we are susceptible. When the virus comes, this is going to be the stage of exposure. Then the symptoms are not yet happening. So this is where the pathological changes are happening in the body, but you are not yet symptomatic. Then you are symptomatic. So this is what we call as the incubation period, right? Where you are not yet symptomatic. So this is the onset of symptoms. Then you have clinical disease, and this is the usual time of diagnosis, right? So after a person has symptoms, they're going to present to the healthcare facility, and that's the usual time of diagnosis. So essentially these 4 points are exposure, pathological changes, symptoms, and usual time of diagnosis. Let's call them A, B, C, and D. If I ask you, where is a screening test gonna come in? Which point does a screening test detect the disease? So, can it be A, before the exposure? It can't, right? Can it be C? Once the person is symptomatic, it's no longer a screening test. So first things first, understand. It's a very common, whenever I ask students who is a screening test for? Normal population or abnormal population? Most of the people tell me normal population. That's wrong. It is for the abnormal population, they just don't know it yet. Can I say that screening is for asymptomatic diseased population? Yeah, so that is what we are trying to do. By a screening test, I'm trying to pick up a disease when the patient does not have symptoms, when the pathological changes are going, but the patient doesn't know it yet. That's the meaning of a screening test. So can I say that when we do a screening test, I am trying to pick up a disease rather than point D, which is the usual time of disease, I'm trying to now take it to B, where the pathological changes are happening. So we are getting that extra time to deal with the disease, that extra time to treat the patient. And this time that you have gained, this lead that you have gained is called the lead time. Did you understand this? So they ask you, what is the definition of lead time? Lead time is the extra time you have gotten between B and D by detecting a disease by screening. Same way, we have a lead time bias. What would the lead time bias be? It is the bias that the patient thinks that they've been sick longer. Yeah, let's say somebody with CA breast, okay? They would have come to us at time D when they feel a mass or they feel some skin changes, and they'll come to you, okay? But what if we detected it by screening mammography? The patient doesn't know it yet, but we found a mass. Now the patient thinks that they have that extra 1 year of a disease. They would have otherwise waited for that 1 year to come to us, but now they've been sicker longer. That's not really true. It's a bias, right? But that's the bias that screening leads to, that patients think that they have been sicker for longer. Do you understand this? So this is the concept of lead time and lead time bias, and these are the basic things, very, very important. Few more terms, confusing terms here. So the first case in a community is called as the primary case, okay? Whoever develops the disease first, whereas whoever comes to the healthcare facility the first observed case is going to be the index case. Yeah, you know how vowels stick together, so they stick together here. So observed is index, whereas first case is primary. So here they'll give you two examples, somebody called Ram, somebody called Shyam. Ram developed symptoms first, but Shyam came to the doctor first. So Ram was primary, Shyam, who came to hospital first, is index. Okay, here rather than the concept, it's Ram and Shyam, the names which make it more confusing. So just stray away from the names, remember the concept. Okay, then we have three time durations here. First is time between primary and secondary case. So between Ram and Shyam, the time was serial interval. Okay, so this is the serial interval. Time between entry of organism and symptoms. So this is what we said, what was stage B. This is what is the incubation time, right? So the time to develop the symptoms is the incubation period. And time between the entry of organism to maximum communicability is called as the generation time. Okay, so these are the three confusing terms. Serial interval, Ram and Shyam. Incubation period, whatever is left is generation time. Okay. Next set of confusers is isolation and quarantine. So tell me, who do we isolate, patients or exposed? So we isolate patients, right? So patients who are confirmed cases are isolated. Okay, so isolation is for the patients to prevent the disease from spreading in the community. Quarantine is not necessarily for patients. Quarantine, the buzzword is, it is for the exposed. Let's say you go to Africa, you've been exposed to yellow fever. India doesn't have yellow fever yet. So if you come back from Africa, you are going to have to undergo a period of quarantine, which is essentially the incubation period. Let's say it is 6 disease. For yellow fever, it is 6 disease, means for 6 disease, you are going to stay in a quarantine facility. We don't let you loose in the population because you might be in the incubation period and you will spread the disease and you don't even know it, right? So that is what is the meaning of quarantine. It is for exposed who may or may not have symptoms, right? Basically, who do not have symptoms. So this is for the exposed, whereas this is for the cases. Now, a little conflicting opinion here. You will study, as to what is primary prevention, what is secondary prevention. We are going to discuss that. And this is a little controversial, but what is my take on it is both isolation and quarantine. Essentially, who are we doing it for? We are essentially doing it from spreading that disease into the general population, right? So my take here is that both isolation and quarantine are primary prevention because the main aim here is to prevent the disease from spreading further, preventing it from going to patients who do not have the disease yet. So that's what is primary prevention. But another take on it is isolation, you are doing it for the patients, so it becomes secondary prevention, whereas quarantine is primary. So this is just a difference in opinion. That's why I'm not even writing it. This has never been asked. It's just something which is a conceptual conflict, so you can go either ways. Okay, so don't argue with anybody, don't fight with anybody. It's just there are two takes on it, nothing is wrong, right? So this is about isolation and quarantine. Now let's talk about these three triangles who have different names. So the first one is the triad of any disease. Okay, so this is smaller triad where they say that for any disease there has to be an agent, yes, there has to be a host, yes, and there has to be an environment. So as simple as it gets, this is the triad. Then it's PSM. So they got to complicate it. So they made it a triangle now. They said that it's a triangle with 4 things. So 3 were there and then they said that time is also important. Yeah, time is also important. So that's triangle. And again, it's PSM. So they made it advanced triangle of epidemiology. So now they just added phrase into it, okay? So advanced triangle of epidemiology, essentially the same factors, but now they've given us different description of the same. So host will include person, characters, demographics. Environment will include place, biological, physical, psychosocial environments. Time will be the incubation period. Agent. So here basically the point is that it's not just restricted to infective disease. They are trying to say that any factor, causative risk or environmental exposure can be associated. So they've just expanded this now to all diseases, because the first two kind of refer to infective diseases. In advanced triangle, they've just expanded it to all diseases, right? So this is about basic concept of health. Very, very important slide from where you usually get one question. Last NEET also you had a question on this. So these are the health indices, very, very easy to remember, okay? Just remember how I ask you to. So the first one is Human Developmental Index, development. Tell me, does our development start at birth or does it start after 1 year? We start developing from birth, right? Milestones start from birth. So here you want to remember that this is life expectancy at birth, LE0. Okay. Second, what do we need for development? We need to go to school. We need knowledge. And for going to school, we need money. So what are the other two things for development? Knowledge and income. Knowledge is the mean and expected year of schooling, and income is the gross national income per capita. Okay, so you want to remember knowledge, income, LE0. Development starts at birth, for development, school and money. Okay, then look at next, physical quality of life index, PQLI. Here just focus on L and I and you are sorted. Okay, L and I tell me that it is life expectancy at 1 year. Yeah. L and I tell me there is literacy. I tells me 1. So infant mortality rate. So everything comes from PQLI. LI, LE1, literacy, infant mortality rate. Global hunger index, your buzzword to remember is 5. So percentage of underweight children under 5. Proportion of children dying under the age of 5. So deaths and underweight, and overall, what does the name say? Global hunger index. So they are essentially checking out of the total population, how many are undernourished, how many are hungry. So if you remember 5, the specific things are done here. Going further down to 2 more indices, which are DALY and QALY. DALY means disability adjusted life years. Okay, so this is disability adjusted life years. Here you want to remember it's a sum total of years of lives lived in a disability and years of lives lost. Meaning, how many years of your lives have you spent with a disability plus how many years of lives lost. Let's consider tuberculosis. How many years of lives of the population have been lost because of disability caused by TB, and how many years have been lost because of premature death caused by tuberculosis, right? So can I say that higher the DALY, poorer it is? Yes. So this is a negative outcome indicator. So basically our aim is to decrease the DALY with any intervention because it's a negative outcome indicator, and in one line you will remember that it measures the disease burden. Okay. On the other hand, what is QALY? QALY are quality adjusted life years. So this is quality adjusted life years, essentially means how many years of life were spent in perfect health. So years of lives spent in perfect health. Can I say higher the QALY, better it is? Yeah. So this is a positive outcome indicator. Do I want to increase the QALY with any intervention? I do. So let's say I launch a new program for tuberculosis. Okay. The aim there is that how many, I have to tell the government that this particular program I'm launching is going to add 3 QALYs to everybody's lives, meaning I'm adding 3 years to everybody's lives where they spent it in perfect health, right? So QALY means how many life years have you spent in perfect health. So this is what we use to measure the cost effectiveness of any intervention. Any program or any plan that we launch, there are two ways to measure. One is cost benefit analysis, one is cost effectiveness analysis. Cost benefit is how much money am I going to make out of it. Cost effectiveness is how much are you contributing to the overall quality of the population, right? So this is where we are measuring it in terms of QALYs, right? Rather than money, how many QALYs will you add, right? So this is what you need to know. So these are two repeat questions. What measures disease burden and what measures cost effectiveness, right? Moving on to time distribution of disease. So time distribution of disease could be short-term fluctuation, which essentially means epidemics. Long-term fluctuation, which is also called as secular trend of a disease. It's a very basic thing but asked a lot, because whenever we say secular, we usually think it's something to do with religion, but not here. So this is where secular trend is a long-term fluctuation, and the classic example being all non-communicable diseases, right? They increase over decades. So you see how diabetes has increased over decades and now it's so prevalent, okay? So this is what is long-term fluctuation, whereas periodic fluctuation could be cyclical fluctuation or seasonal fluctuation. Seasonal example, dengue, right? You see how dengue will increase during the time of monsoons because of the mosquitoes breeding, right? So on and so forth. Cyclical means diseases which occur, on a cyclical basis. For example, we will see that measles will come every 2 to 3 yearly, whereas rubella will have a 6 to 8 yearly cycle, right? So this is what is called as the cyclical trend, right? So these are just simple terms you need to know. What is very interesting are the types of epidemics from where you can get questions, okay? So concept is very simple, but the names here are a little tricky, okay? So I'll give you examples and that's the best way to remember, okay? Let's say that a group of 4 friends went for dinner, okay? They shared a bowl of soup. All of them are sharing the same bowl, which is infected with salmonella. Now, all of them are going to develop food poisoning at the same time because they have been exposed to the same source. So, when you have a point source, which was the soup, and all of them got the disease from that source within one incubation period. So, this is called as point source single exposure, right? Another scenario, let's say you have typhoid Mary. Yeah, you have a cook who works in a restaurant who has typhoid, who is a typhoid carrier. Now, in her shift, whoever gets exposed over a period of time are going to get the disease, right? So, is it still a point source? Yes, that Mary is the point source. But now, the cases are going to rise over multiple incubation period. Are you understanding this? So, this is point source multiple exposure. Okay, so both of the examples you remember, confuse these terms. Okay, so in both of the examples you have to remember that the source is point source. Whether it is one incubation period or multiple incubation period, you have to see. Okay, then the most common type of epidemics are propagated epidemics, right? So look at what happened with COVID, right? So in COVID you had one case, 1 gave to 3, 3 gave to 15, 15 gave to 100. So this is how it started propagating. So this is propagated epidemics, whereas this is an interrupted type of epidemics like influenza. You will see how flu outbreaks will happen, then will recede, then another outbreak. So this is called interrupted outbreaks, right? So these images are very, very important. Next, look at this image. What do you think this is called when you plot the cases in a geographical map? This is what we refer to as the spot map, right? So this is a story of a boy called Jon Snow. He was very sad in life because everybody told him that Jon Snow, you know nothing. So he was very sad. And then one day he was just sitting idle and then he said, let me just plot all of the cases of cholera which are happening around my village, Sparta. Okay, so he started plotting and then suddenly he realized that out of this entire area, everything is clustered around Sparta. So it must be Sparta which is the cause. And for this, everybody was so impressed that Jon Snow has found us the cause of the disease in Sparta, they named him father of epidemiology. So from knowing nothing, he has now become father. So and remember, John Snow is the father of epidemiology. Whereas who gave definition of epidemiology? That was another John, but he was John last. And remember, we remember definitions at last. Okay, so last is definition, whereas our father is John Snow for this spot map. Okay, and do you want to know who is the father of public health? PSM being PSM, the father of public health is cholera. Our father is a disease. Okay, so cholera is the father of public health. So this is what you want to remember about the time distribution of disease and some miscellaneous facts. This topic is very, very scoring. Okay, this is so conceptual. You just hear it once and now you don't have to revise it ever again in life. Okay, so this is levels of prevention. Here, just learn the concept and then apply to whatever example anybody can ask you. So primordial prevention means that there is no risk factor, let alone disease. We are trying to eliminate the risk factor only. The example being health education. Overall, trying to have a healthy lifestyle from birth. Imagine somebody from birth never smoked a cigarette, never had any alcohol, always ate good homemade food, no junk food, nothing unhealthy. Very rare, right? So that is called as primordial prevention, where you didn't even allow risk factor to come. Or anytime you're trying to eliminate a risk factor, let's say just eliminate alcohol from the population, that's called primordial prevention. Okay, primary prevention is what we most of the times do. Okay, so another hack is, if you don't know the answer, mark primary. Okay, so primary prevention is when risk factor is there but disease has not come yet. Let's say that there is somebody who's drinking a lot of alcohol. Before they develop alcoholic liver disease, they cut down on alcohol, they stop. So risk factor was there, but the disease didn't come. So this is called primary prevention. So it could be general like this, called health promotion, where you cut down on smoking, you cut down on alcohol, you start going to gym. So general healthy practices are health promotion. But then you have specific protection. Classic example being vaccine, yeah. So why do we vaccinate? Risk factor is there, but before the disease comes, vaccinate and develop your immunity. So that's called primary prevention. Another example, contraceptives, right? What do contraceptives do? In this case, babies are the disease. So risk factor is there, but baby is still not there. Disease is still not there. So use contraceptives, primary prevention. Any word which has prophylaxis in the name, yeah, what does prophylaxis word itself tell you? It tells you that you do not have the disease, you have been exposed. Let's say even post-exposure prophylaxis. What does it mean? It means that you have been exposed, but before you develop HIV, take the drugs. So this is what is primary prevention. Secondary prevention means now the disease has come. You can either deal with it by early diagnosis or treatment. So both of these become secondary prevention, and the classic example is screening. So as we established, screening is for the diseased who are asymptomatic. So always remember, SIR is SIR. So screening is secondary prevention, whereas treatment obviously is secondary prevention. So treatment you will recognize easily in the question. Screening you want to remember is early diagnosis. Tertiary is let alone disease. Now the disease has left some disability also, and we are trying to deal with that disability. So either you are trying to limit the disability or you are trying to do the rehabilitation. So this could be, for example, doing physiotherapy. Let's say somebody has polio-induced paralysis. So they are doing physiotherapy, they are using crutches. So all of these things become tertiary. What about spectacles? If you wear specs or even say contact lenses, are you treating the disease? No, your refractive error is not getting treated. You are only doing the rehabilitation, right? So specs or contact lenses become tertiary prevention. So that's the concept. Let's try and apply it to few examples. So vaccines, what are vaccines? We have established that's primary. Post-exposure prophylaxis, the very word prophylaxis tells us that you have the risk factor but not the disease. But if I say BCG, which is a vaccine for CAUB, now I'm using it for treatment, right? So then it becomes secondary. Contraceptives, primary prevention. But if I use contraceptive for PCOD, OCP for PCOD becomes secondary. Now, in screening, let's complicate this a little. So, we have two kinds of screening. Prescriptive screening are all of the screenings that you know. For example, getting a pap smear done, getting a mammography done, getting a PSA level done, right? So, all of these screening investigations remain what we discussed secondary. But there is another kind of screening which is called prospective. Prospective has an O, which means it is for others' benefit. I am not doing it for the person getting screened, I am doing it for the others, right? For example, let's say you apply for a US visa. Before you go for the visa, they will ask you to get a chest x-ray done, they'll ask you to get a Montu done to check whether you have TB or not. Are they trying to diagnose your TB? They don't care. They are trying to prevent TB from coming to US, right? So, such a screening is called prospective screening, and now this is what? This is for primary prevention, because now you are doing it for others' benefit who have risk factor but no disease. Are you understanding? Another example, right? HIV. Basically, you are trying to check HIV during antenatal screening. You are trying for others' benefit. STD, blood donors, right? If you screen the donated blood for what all diseases we screen for HIV, we screen for Hep B, we screen for Hep C, we screen for malaria and syphilis. This is a list we had learned in HEMAT. We do not screen for dengue. So now when I am screening this, I am not trying to diagnose the person who donated. I am trying to prevent the recipient from getting these diseases, right? So such a method is called prospective. So just remember, are you doing it for others' benefit? If the answer is yes, it's primary prevention. Okay. Next, what about physiotherapy for polio? Easy. Tertiary. Chemo prophylaxis in contact. So they have been exposed but aren't diseased yet. Mosquito repellents, nets, DDT all come under primary prevention. Mosquito is there but disease is not there. Iron folate in pregnancy, primary, right? We are trying to prevent anemia from happening. Seat belts and helmets, again primary. If you've come out on the road, risk factor is there, but you are not dead yet. So wear seat belt helmet, right? So this is the concept that you have to use and you can answer any question here. All right. Next topic is a lot of stuff. So we have to deal first with control versus elimination versus eradication. Control and elimination are geographically localized concepts. Control means trying to reduce the level such that the disease is no longer a burden. So this is control such that the disease bring down the level such that it's no longer a burden. Elimination means bring down the disease such that the chain of transmission is interrupted, means the disease is not being transmitted. So bring it down to a level where the chain of transmission is interrupted. So both of these are local phenomenon, right? Eradication is a global phenomenon where get rid of the organism. There is no longer that organism existing in the universe, except maybe in labs, in control settings. So that organism is not there globally. We have only eradicated one disease, which is smallpox. And when was it eradicated? 1980, 8th of May. We have eliminated 4 diseases. So elimination, when I say, what do I mean? Means India has eliminated 4 diseases. Guinea worm has been eliminated. Leprosy way back in 2005, and you want to remember the criteria for leprosy elimination was 1 in 10k. If you bring down the population to less than 1 in 10k, that's when the chain of transmission breaks, and that's the definition of elimination. Yaws and neonatal tetanus, right? So these are the 4 diseases we have eliminated yet, right? So this is what we need to remember about the definitions. Now let's talk about surveillance. So what is passive surveillance? Passive surveillance means nothing but the patient is now coming to the hospital. So patient seeks treatment in the hospital is passive surveillance, means you are not doing anything, you are taking the patient. Active surveillance means you are or anybody is going out in the community trying to find actively the patient. So this is where we are going in the community to find the patient. This is done for various diseases in India. For example, malaria. In malaria, you remember every fortnightly this multi-purpose worker male, right, who is at the sub-center level is going to go and find out if there are any patients of fever, right? So this is malaria. We do it for tuberculosis, where we're trying to seek out cases from the community. We do it for poliomyelitis, Kala Azar, right? So these are the diseases where active surveillance is being done. Let's talk about National Polio Surveillance Program. Important, okay? So this is where we complete the entire program right here, right now. Everything about polio that you need to remember. First of all, a few points about each of the polio strains. So P1 is the strain that led to the most common it was the most common strain to lead to epidemic. So, remember, P1 is the most common. P2, the specific point about P2 you want to remember is this is leading to vaccine-derived poliovirus. Very, very important, which is circulating form. So, what is the importance of this? This is a phenomenon where, let's say you are giving oral polio vaccine, which is live attenuated virus, okay? So, out of this, one of these viruses becomes virulent and causes the disease. So, that is called vaccine-derived polio virus, okay? So, this is happening most commonly with P2. Now, what do you think? Should we take this risk? P2 is also something which was the least common, or it was the one which was most easily killed. Now, if it was easily killed, why are we giving it as a vaccine and taking the risk when it is the most common one to cause BTPV? Using that logic, that's why we have removed the P2 strain now from OPV. So, that is the reason for OPV switch, where from a trivalent OPV, we now give bivalent OPV, right? So, this is what we need to remember. And this particular event was done on 25 April 2016. So, this is what is called as the OPV switch year or day. Okay, so this is about OPV switch, and I hope you understand. Whereas P3 is what leads to VAPP. What is VAPP? This is vaccine associated paralytic polio. Now, this is not something where something is becoming virulent. This is where there is some immune aberrant response, right? So, an aberrant immune response happens because of which the vaccine strains now lead to the paralysis. So, this is not something where you have an infection. It's some immunity abnormality with the vaccine. So, this is what leads to VAPP. It is an adverse effect associated with the vaccine. It's not something that is happening because of the vaccine per se. Are you understanding? So, this is what is an adverse effect following immunization, which is VAPP. So, this is because of an aberrant immune response. So, these are the 3 one-liners. Each strain gives you 1 one-liner. P1 most common cause of epidemics. P2 was vaccine-derived poliovirus, whereas C is vaccine-associated paralytic polio. And these are terms which I have seen students mix up a lot. Okay, so I hope this is clear. Now, let's talk about surveillance. We're talking about active surveillance. So, this is what we do. We do this surveillance of acute flaccid paralysis. Any case of acute flaccid paralysis that we get in the community. Now, what all could be the causes? We have studied this in neuro, right? It could be poliomyelitis, it could be Guillain-Barré syndrome, it could be any meningitis or transverse myelitis, right? Which can lead to acute flaccid paralysis. So, any case which is reported as acute flaccid paralysis must be checked for polio, and this is done by this SMO, who is the surveillance medical officer. Okay, so what is the criteria? Lots of numbers here. What you need to remember here is anybody who is less than 15 years with acute flaccid paralysis have to be surveilled. What do? We take 2 stool samples from them, which are 24 hours apart, and this should be done within 14 days of onset of paralysis. So, within onset of paralysis, within 14 days of onset of paralysis, we have to take these 2 stool samples. Now, you have to remember one thing here, that you need to take these samples within 48 hours of this being reported, okay? So, let's say that somebody reports a case of AFP. These stool samples have to be collected within 48 hours of that reporting. So, within 48 hours of reporting, you collect it, you take 2 stool samples 24 hours apart, within 14 days of onset. So if more than 14 days have passed, there is no point of collecting it. Okay, so that's what is the first point, 2 stool samples. How do you send it back? So these stool samples have to be sent back using a reverse cold chain method, where you have to store them at 2 to 8 degrees Celsius, and they should reach the lab within 72 hours. So various criterias. How I remember this is, there is 24 hours, 48 hours, 72 hours. So 24 hours apart, 2 sample. Within 48 hours of reporting, we have to take this, and within 72 hours, they have to reach the lab. Okay, so this is what you need to remember, and very, very important, we have to do a residual paralysis check at 60 days. I think this has come in one of the exams. Okay, so this number is important. So within 60 days, you should do a residual check. Now, if the surveillance is going well, there are a few indicators if you are doing the program well. The indicators are that at least minimum 1, so at least more than 1 out of 1 lakh cases should be reported of acute flaccid paralysis in a year. So in a year, you must find at least 1 in 1 lakh population acute flaccid paralysis case in a year. Secondly, 80% of the stool samples that are reaching the lab are adequate. 80% of the patients are getting a residual paralysis check at 60 days. So 80% of 80% adequate stool sample, 80% residual paralysis check. So these are the 3 impact indicators that you want to remember. Just a specification here, you want to remember that out of this at least 1 in 1 lakh acute flaccid paralysis, this should be at least 1 in 1 lakh non-polio case of acute flaccid paralysis detected annually, right? So this is all about the polio program that you want to remember. Next, while we are at it, let's just talk about HIV surveillance also. What we do in HIV is sentinel surveillance. Sentinel surveillance ka meaning is hidden cases. So this is what you need to remember, that this is to find out hidden cases. These are not going to be actively reported in the community as well, but we have to find them. So this applies very well to HIV. So this is important. How do we do HIV sentinel surveillance? So first of all, the buzzwords, it is biennial. Biennial means once in 2 years. Okay, it is not biannual, it is once in 2 years. Okay, so I'll just write it like that. So this is once in 2 years, and it is unlinked anonymous. So here we do the surveillance in 2 groups. One is general population, one is high risk. Now you can't go house to house and ask for blood sample for an HIV test. Patients will not agree, or people will not agree. What you need to remember is, we anyways are screening our ANCs. You remember that here we have what kind of approach, opt in or opt out? We have an opt out approach for ANC. So this is what we are using. We are anyways checking the ANC HIV, and that's an opt-out strategy, which means that unless they say, no, I don't want to get checked, we are going to be screening them, right? So we are anyway screening our ANC, so we take them as a proxy for general population, right? So ANCs are a part of the sentinel surveillance. And right now only you remember what is the definition of a high risk area. A high risk area is where your general population, meaning your ANC ka prevalence, is more than 1% positive, okay, and your high risk groups are more than 5% positive. So now let's talk about high risk. So I've integrated the numbers here itself. So for high risk, what all do we check? So 3 high risk groups: commercial sex workers, men who have sex with men, and transgenders. These are your high risk groups. And then there is a group called bridge group. Bridge group means people who transfer the disease from the high risk to the general population, and that includes single male migrants, truck drivers. All right, so these are called as high risk. If the prevalence here is more than 5, this is called as high risk area. So in sentinel surveillance, you want to remember, we are screening ANC and high risk, but not STI clinics. So just one word for you: sentinel surveillance is not in STI clinics, right? So this finishes a lot of concepts about polio and HIV along with surveillance, okay? Now we are venturing into epidemiology. So epidemiology, the first thing is to understand the difference between ratio, rate and proportion. Ratio, you want to remember that numerator and denominator have nothing to do with one another, right? For example, maternal mortality ratio, we'll talk about it, but this is where you have the number of maternal deaths upon live birth. Yeah, so one has nothing to do with the other, and that's called a ratio. Rate is something where you have unit time into factor. So rate is where you have time taken into consideration. Classic example being incidence. What is incidence? Incidence are the number of new cases which develop upon the population at risk into 1000 per unit time. So rate first of all takes into account unit time. Okay, so new cases upon population at risk into 1000. Proportion is simple percentage, right? For example, prevalence. Prevalence is how many total number of cases do I have upon the total population. For example, out of 100 people, I find that 5 have TB. 5% is the prevalence. Okay, so proportion is simple percentage where numerator is a part of the denominator. Okay, so numerator has to be a part of denominator expressed as a percentage, right? So these are the basic definitions that I'm sure you know. So with this we have done prevalence and incidence definitions also. Okay, so how are they two related? The two are related by PID. Okay, so you remember prevalence is incidence into duration. Prevalence means total number of cases. Will that depend on new cases? Yes. Will it depend on how long these new cases are there in the population? Yes. So with this, they ask this table, which is actually very simple once you understand P equals I into D. So let's say that I have some intervention with which I can increase the survival of the population or the diseased. So now how will that change the incidence? If you can increase the survival of your patients, the incidence is not going to change, right? So this is not going to change. But will the prevalence increase? Yes, because you are increasing the duration of disease. So now prevalence increases because P equals I into D. If there is more mortality, can I say the duration is decreasing? Incidence doesn't change, but now the prevalence decreases. Same way, faster recovery is happening now with the patient, so the duration of disease decreases, so prevalence decreases. But what if you vaccinate? If you vaccinate, primary prevention, now the incidence will decrease and again prevalence will decrease because prevalence is a measure of both incidence and duration. What if you give primordial prevention? Again, you remove smoking, only the incidence of CA lung will decrease and hence the prevalence will decrease, right? So it's so simple, don't have to see this again, okay? Let's do the other definitions now. Attack rate is the same as incidence except that it's for an infectious disease, right? So this is what we are doing for infectious disease, everything else remains the same. So attack rate, you want to remember, are the number of new cases. Attack rate are the number of new cases upon the population at risk, right? So same thing. For example, there is an epidemic of influenza going on. How many new cases did you find upon the susceptible population? Into 100. So this is the only thing which is different, that the multiplier is 100, and attack rate tells us the extent of an epidemic or an extent of an infection, right? What is a secondary attack rate? So this is where you take into account secondary cases. So here the numerator is going to be the number of secondary cases. Means I don't take into account primary case, meaning RAM. If RAM is the primary case, RAM is subtracted from the numerator here. So this is where I take into account only secondary case, and also the denominator will now only be the susceptible population. Meaning, will I include primary case here? No. So this is where the susceptible are only included, and something very important in the numerator is number of secondary cases who are affected in one incubation period. I don't want totally. So if this is RAM and RAM has exposed 4 different people, right? My numerator is going to be these 4 who have been in contact with RAM in one incubation period, right? So if 4 people develop influenza after meeting RAM, those 4 people are going to be our numerator. Upon how many were susceptible? How many susceptible did RAM meet? So if RAM met 10 people, who were susceptible, and 4 developed it, it becomes 4 upon 10. Yeah, so we take the number of susceptible people. So susceptible people, does it include Ram? No, obviously Ram is not included anywhere. Primary case is not included anywhere. Did you understand this? So primary case met 10 people in one incubation period, out of which 4 developed disease in one incubation period. It becomes 4 upon 10 into 100, right? So this is a measure of the communicability. So if I say what is the best measure of communicability of a disease, can I say secondary attack rate? Yes, you can. So this is what you need to remember: number of cases in one incubation period upon the susceptible population. So you just remember, don't include the primary case or the cases, right? So don't include the primary case who are already infected. Fine. What is case fatality and what is proportional mortality? Very, very simple, just that people confuse both of them. So if you just read the name, you will know. Case fatality rate means out of 100 cases of TB, how many died? So how many deaths upon the total number of cases of that particular disease into 100. So let's say 10 people die out of 100 cases of TB, 10% is case fatality rate. This indicates the virulence of a disease. Can I say that if 10% is the case fatality rate of TB and 20% patients of cardiac arrest are dying, who is more virulent? Cardiac arrest, right? So both are not infective, but still we can use this as a measure of virulence of a disease, the killing power of a disease, right? If I talk about proportional mortality rate, proportional mortality, this is where I am taking into account all deaths. Out of 100 deaths, how many were because of TB, right? So this is where, let's say I am taking into account number of deaths because of a certain cause which I am estimating upon the total number of deaths, right? So this is what is proportional mortality rate. I hope this is clear. Out of total deaths, 10% was because of TB. Out of total cases of TB, 10 died. So I can see how it is confusing, but once if you get it, it's pretty simple, right? This is what we need to know. Now, what you have to remember, whenever you are measuring any mortality rate, we would want to standardize it as per the age specific death rate, okay? But if that age specific death rate is not available, what we do is indirect standardization. Just remember this line. I feel this has been asked in AIIMS in an old exam, so I just want you to remember that ideally we standardize. This is something which is not really applicable here. This is more in demography, but I've just told this to you right here, right now. Just remember this. If age specific death rates are not available, this is what we use for estimating the death rate, crude birth rate. Crude death rate is crude. But if you measure age specific birth rate, death rate, you get better data. But if that's not available, we can still do indirect standardization. So just remember this word, indirect standardization, right? Now let's get into the designs. Okay, so very, very important. One question, extremely scoring. This is one thing you should never get wrong. Okay, so types of epidemiological studies in general are 3. So we have descriptive, analytical, experimental. Descriptive study is formulate a hypothesis. So this is where you are going to formulate a hypothesis. I'll give you an example that you'll relate to. Let's say there is one girl and one boy in your batch who are hanging out a lot, recently. So there's always this one guy in every batch who is the first one to have their radars up and notice something, right? So this guy now sees them that, oh, something is going on. So this is the guy who is going to formulate a hypothesis. This is called a descriptive study. So he goes and tells this to his friends that this is what I have observed, okay? Are they going to believe him? They're going to say that you keep telling us all of this every other day. You have to now test this and then tell us, okay? Confirm karke bata. That is what you're going to tell him. So for that, now he has to do an analytical study. He has to test the hypothesis that he has made. So now what is he going to do? So now he has to conduct a cohort study where he's going to follow them now from morning till evening, right? Temporality is important. So he's going to follow this boy and girl from morning to evening to see what's happening. Okay, they're going to boys hostel together, they're going to mess together, they're going to library together. So this is what is the analytical cohort that he has created to test the hypothesis. Yes, I have now tested. But the final straw is when you have to confirm the hypothesis. So far, do you agree he was only observing? Yeah. So both of these are just observational. He was not intervening or he wasn't doing anything. Yeah. So these are both observation. To finally confirm any hypothesis, some experiment or intervention needs to be done. So how do we confirm this now? So you bring one boy from your gang, another girl from your gang and send to respective parties, do a crossover trial. If they don't get attention, it means hypothesis confirmed, right? So this is what you have to remember. This is experimental. So testing, confirming and formulating. All right. So formulating, testing, confirming, these are the types of studies. So another way to divide, can I say that first two were only observation and last was when we experimented. So observation or experimental. There are various guidelines now. So in red you see are the names of the guidelines. Just give it a glance. So observational is Strobe guidelines. Here observational studies see the unit of study. Is it individual based or is it population based? If it is population based, very, very important, this is ecological correlation aggregation study. Ecological study is the population study, very, very important. Other names of the same are correlation and aggregation. In ecological study, what you have to remember is the data that you are getting is the secondary data. This is where I am comparing populations. Let's say I do a study to compare how much is the per unit consumption of chicken, right? So I say that India has 5 gram, US has 15 gram, So basically what I am trying to compare are populations. The gross problem with this is what is called as ecological fallacy. So one, the data we are using is secondary, and second, ecological fallacy. Means what? Let's say in India there's a pure vegetarian and he is saying, I have never touched a chicken in my life. How are you saying I'm eating 5 gram on a day-to-day basis? So the fallacy is that the data of the population can't be generalized to every single unit of the population, right? So that is the meaning of ecological fallacy. So these are the two things. Now coming to individual based. So descriptive, remember descriptive formulating hypothesis is done by simplest studies, case report, case series. You find an interesting finding, you report it. You find a series of similar findings, you report them as case series. The guidelines for case report is CARE. So naam mein hai CARE, right? Analytical studies are three, very, very important. One is cross-sectional study. Cross-sectional study means, let's say there are 50 people in a class. I measure everybody's blood pressure and I say that, okay, 2% have high BP. So basically, this is a snapshot. I took a picture right now. No aage piche. Nothing follow-up, no past history. All I am doing is taking a snapshot of the population. This is what is called as collecting primary data. Yeah, so this is what gives me prevalence. It doesn't tell me new cases. It only tells me right now, out of the total population, these are the number of cases. So this is what is giving me prevalence. Very important. Then, when you have some aage piche associated, case control versus cohort. This is something you should never confuse because answer is in the name itself. Case control, what does it mean? I have cases and I have controls. I ask both of them about the risk factor. So this is where you are moving from the disease to the exposure. So let's say I take CA lung and I take normal population. I ask both of them about their smoking history. So this is case control. Whereas cohort is where you start with exposure. So in case control, start with disease. Here you start with exposure. So I take a bunch of smokers, I take a bunch of non-smokers and I see them for the next 10 years and see who develops CA lung. That is cohort. So who gives me new cases? Cohort gives me new cases, right? So this is what is the best study because it is the incidence study. It tells me new cases. It tells me about incidence, right? So this is what we need to know. Experimental studies, where we had to intervene. So one is randomized control trial. This is where you take your patients, you take controls and you give them both the drug and the placebo, and you see the effect. For RCT, you have consort guidelines. This is a repeat question. You have clinical trial, crossover trial. Crossover trial just essentially means that, let's say this is the group which is getting drug. This is the group which takes placebo. After a washout period, you then do a crossover where this group is now going to get the drug and this group now gets the placebo. Okay. Non-randomized are field trial, community trials, which are usually done, for vaccines, etc. So this is what we need to know about the types. Just adding on to this further, now look at this, okay? So just in a descriptive manner, we can describe this. Can you tell me, looking at the schematic, whether it's case control, cohort, cross-sectional? Look at where we are starting always. You're starting with disease, non-disease, and finding out exposure. So what is this? You're starting with case and control. So this is a case control study. On the other hand, look at this. You're starting with exposed, non-exposed, smoker, non-smoker, and then waiting to see who develops the disease. So this is what we call as cohort. Just to be specific, this is what is prospective cohort. Yeah. On the other hand, look at this one. What is the problem with cohort? It's all good. It tells us incidence and everything. But then you have to wait for so many years, right? What if I can still keep that temporality and not wait? That is what is called as retrospective cohort. So retrospective cohort is where, now let me just follow the same order. Remember, the starting point is still exposed, non-exposed, but let's say I pick up 10 files. 10 files of smokers, 10 files of non-smokers. From the files, I go on to see who has CA lung, who has no CA lung. So that is where I still maintain the temporality, but it's all retrospective. So it retains the advantage without the time penalty. Yeah, so this is what we need to know. Final bit of complication is what is called as a nested case control study. Nested case control, everything is in the name. You were doing a cohort, but while you were doing a cohort, in between you nested another study. So let's say I have this cohort, okay, of smokers, non-smokers. Within that, I find people who have CA lung, people who do not have CA lung. So within this cohort only, you did a mini nested case control study. All right. So this is about the different study designs. Now, let's look at the examples. So, which out of these is the best for multiple exposures? What do you think? So, it has to be case control, right? In cohort, you are defining your exposures at the beginning. How will you have multiple exposures starting with smoking, non-smoking there, right? So, in case control, if you have CA lung, now I can find multiple things. Were you a smoker? Did you drink alcohol? Did you work in asbestos? Many things. Best for multiple outcomes. So now a smoker can develop 10 other things. So how do I know that? I can know that in a cohort. Rare diseases. So obviously for rare, it's not wise to do a cohort. You wait for 10 years, nobody develops a disease, right? So you want to do a case control for rare diseases. And that nested thing is the one which comes in here. So nested case control you want to do for rare or expensive investigations, right? So I'll give you an example. This is what they'll tell you. Let's say I have a labor room where babies are getting born. Every baby who's born, I take the blood sample, okay, and I store it. I'm doing some sort of a cohort study where I'm taking the samples of all of these babies. In between, let's say we find out that there is some new teratogenic effect which has come, and we hypothesize that it's because of the use of oxytocin. So now I already have this data and have the blood report. So now I can use this cohort to do a mini case control where I start with patients who have developed this teratogenicity and who have not developed this teratogenicity, and then go on to find out how much oxytocin they had gotten, right? So this is where you are doing a cohort. In between you nested a case control. So this is for rare, expensive investigations, you can remember. Fine. Then multiple names. What is incidence study? As we established new cases, so cohort. What is prevalence study? As we established cross-sectional study. Unit of study in ecological study is population. Everywhere else it's individual. And you want to remember, intention to treat is a term we use for randomized control trials. Intention to treat trial, that's what you remember. Now, talking about bias, very, very important. So, bias is what is called as a systematic error. What are the kinds of biases we need to understand? First is selection bias. Selection bias is usually, it can be there in anything, but it's usually there in case control, where the type of cases and controls you're going to select is going to impact the result. Recall bias. Recall bias again predominantly in case control. Imagine somebody who has smoked a couple of cigarettes for a year of their life, they smoked and then they quit. They didn't develop CA lung. Whereas somebody who smoked cigarette for 1 month and went on to develop CA lung. So, who is going to remember that brief period of smoking? It's going to be the one who has CA lung, right? He's going to remember every single cigarette he has smoked. So, that is recall bias, where you will recall the risk factor exposure more if you have the disease rather than when you don't have the disease. Then Burkinsonian bias is a type of selection bias which happens when you select your data from hospital patients. So this is what we usually do. We don't go house to house to get our samples, right? We are going to get our samples from hospital. So when you have all of your cases and controls from the hospitals, can I say that these controls are not really ideal controls? If they've come to the hospital, there is that inherent bias which sets in, right? So if your patients, if your study group, complete study group is from hospital patients, whether or not they have that particular disease or not, this is called Burkinsonian bias. Attrition bias is seen in cohort, as is self-explanatory. You are going to follow them up for years now. So some patients will say that we don't want to participate, they'll move around, right? So they'll migrate. So the loss to follow up or attrition happens in cohort studies. Hawthorne bias. Hawthorne is also something that happens in cohort. This is called as Hawthorne attention bias. What does that mean? If there is a smoker of your cohort study, right, he keeps seeing that this doctor is coming every 6 months to see if I have developed CA lung or not, he'll also think now that maybe there is high chance I will develop, maybe I should change my habits. So basically, when you change your behavior, when you are being observed, that bias is called Hawthorne attention bias. Another bias is called Pygmalion bias, which is called as Pygmalion researcher bias. The researcher's belief in the result might sometimes affect the data. Okay, so you want to remember that if the researcher strongly believes in some sort of a result, that might be biased. Okay, so this is Pygmalion, and that is where blinding kind of comes in and removes it, where you don't tell the researcher who is exposed, who is placebo. Fine, so just have to know the term. Another bias is incidence prevalence bias, and this is also something which may be asked, called as Niemann bias. Niemann bias is also called survival bias. It means that I am going to take into account the data of patients who have survived, obviously, right? Because we are not taking into account patients who did not make it to the hospital. So in itself, it's a bias that I'm not even accounting for the patients who have not reported to the facility or who have already died. So this is what is the bias, which is called as incidence prevalence. Incidence could be high. There could be many cases, but then maybe they did not make it. So this is the incidence prevalence bias. Everything is in the name. So this is where you don't take into account the ones who are not surviving. Fine. So this is incidence prevalence or Niemann bias. So these names you should be familiar with. Now let's talk about another very, very important thing, which is confounding versus effect modifier. Confounders, what you need to remember, are factors which are related to both the exposure and outcome. Very, very important. Let me give you an example. Let's say we are considering smoking as a risk factor for CA lung. A confounder is people who drink caffeine, who drink coffee, right? Because it's been found that people who drink coffee tend to smoke more and vice versa, and caffeine might also be a risk factor for CA lung. Let's hope it is not, but it might be. So this caffeine now becomes a confounding factor because it is linked with both exposure and outcome. So what is a very easy way to remove this? is to match, right? Just don't take any coffee drinkers in your cases or control, or take all coffee drinkers in your cases and control. So that will match. So this is what can eliminate only known confounders, but there could be many such factors which we don't even know exist. So what is the best for known plus unknown? So for known confounder, as we discussed, it's matching. For unknown, we have many methods like randomization, restriction, stratification, stratified randomization, statistical modeling. What do you think is best? Why do one when you can do two? So stratified randomization. So this is what is the best. Okay, so this is overall the best for confounders. So stratified randomization. Now, what does blinding do? Blinding does not remove confounding factors, very easily confused. Blinding removes the bias, right? So B for B is what you want to remember, that blinding is to eliminate bias. Blinding can be single, double or triple. Single blinding means that the patient doesn't know whether he is in the drug group or the placebo group. Double blinding means neither the patient nor the doctor knows as to which group a patient is in. And triple blinding is when neither patient, doctor or the data analyst, the researcher also doesn't know which group. So obviously what is the best? If you ask me best, it's triple blinding, but it's very rare to do triple blinding. Most of the times we do double blinding. So most commonly it is double blinding which is done, right? Very important. What does randomization do? So randomization, you want to remember, is the definition is that every participant has a known and equal chance of being a part of the study. We randomize. This removes both bias and confounding. Very, very important. So what did we do? We did confounders के लिए matching for known confounders and many factors for known and unknown. Blinding is only for bias and randomization is both bias and confounding. So this is sorted. Then there is just one more area which is called as Hill's criteria of causality. Smoking causes cancer lung. I can't just make a statement based on one study. There are many criteria to be fulfilled which are under the Hill's criteria. Out of that, the most important one is temporality. It means that smoking must precede CA lung, right? So that's the most important one to establish, is the temporal link between the two events. Most difficult to achieve Hill criteria is specificity, because it says that one factor is specific to this and that may not always be true, right? So for me to say that smoking is causing CA lung, smoking is only causing CA lung or CA lung is caused specifically by smoking, it's a very, not only but specific, it's very difficult to establish, right? So this is what you need to remember as far as one-liners are concerned. The whole table of causality list, you can just go through it once, just do a Google search and see what are the other Hill's criteria, right? Now, try to distinguish confounding factor from effect modifier. So now let's talk about what is an effect modifier. I'll give you an example. Let's say again we are checking smoking with CA lung. Here asbestos becomes the effect modifier. Means somebody who is smoking in CA lung, if they work in an asbestos factory, their risk of CA lung is going to increase, but there is no independent relation between the three. People who smoke are not likely to work in asbestos factory or vice versa, but if they are also working in asbestos, now their effect is going to be modified. So this is what is something very important. If you see this diagram, very beautifully given, you'll understand this concept, right? So this is about epidemiology. Now let's go to the formula from these studies. Who gives me odds ratio? So case control is going to give us the odds ratio, whereas all of these risk, relative attributable population, are going to come from cohort. So cohort gives me most importantly relative risk. Let's talk about odds ratio. Let's say we did a case control study. So with the result of the case control study, now we have to make this 2 by 2 table. Whenever you are making a 2 by 2 table, remember disease will be on top and risk factor will be on the side. Okay, how to remember? If you have a Didi, yes, an elder sister, she'll always be greater than you. Okay, so she'll always get more respect. Didi comes on top. Okay, so always remember D comes on top. Here Didi is disease. Okay, so disease is on the top. So you have disease positive negative, risk factor positive negative, A, B, C and D. So this is how you make your 2 by 2 table, and odds ratio becomes this cross product, which is A into D upon B into C. This is how we get odds ratio. Relative risk is simple. It is the incidence in exposed upon incidence in non-exposed. Fine. So this is what you have to now do. So odds ratio and relative risk, how do we interpret them? If this is more than 1, what does that mean? It means that it is a risk factor, right? So this means that if the odds ratio is more than 1 or relative risk is more than 1, it is a risk factor. Causative or not, we have to see, but it's a positive risk factor. On the other hand, if it is 1, means there is no association. It just tells me that incidence in exposed and non-exposed is the same, means smoking has no association. On the other hand, if the incidence in exposed is less than non-exposed, it means that our factor is likely to be protective, negative association, right? So that is what it means. What you have to take away from this is, let's say I give you a result, right? That there is a study which I did whose result was 0.5 to 5. Relative risk is always a range. It's not a number, it's a range. Let's say it comes out to be 0.5 to 5. Is this study valid? It's not valid, because you can see on one hand we are saying it's less than 1. 1 is also a part of the range. More than 1 is a part of range. So if 1 becomes a part of the range, it is an invalid study, because you are saying all 3 things. So this study is invalid. What if I say 1 to 5? Is it valid now? It's still not valid, because now you are saying on one pole that there is no association, and then you are saying it's 5 times associated. Again, not valid. But if I say the relative risk is 1.1 to 5, yes, now we are talking. So this is what is valid, because now you commit to one thing. So essentially commit, either causative, protective or no association. You can't say everything. So this is what you have to do with this RR data here. Talking about attributable risk is incidence in exposed minus non-exposed upon exposed into 100. Okay, so exposed minus non-exposed upon exposed into 100. This, for example, comes out to be 75%. It essentially means that 75% of CA lung can be attributed to smoking, right? So this is a number which is very important to whom? It's very important to clinician, right, who is seeing that CA lung, that 75% of these cases are happening because of this risk factor. On the other hand, population attributable risk is incidence in total population minus non-exposed upon incidence in total into 100. So instead of exposed, you replace it with total population. Let's say this comes out to be 33%. What does it mean? It means that if you eliminate smoking, 33% CA lung will disappear from the universe. Okay, so this tells us the benefit of primordial prevention. Are you understanding this? And who does this help more? This is more helpful to the epidemiologist who's working on removing this risk factor. Are you getting it? So, how much percentage of disease can be attributed to that risk factor is attributable. If I eliminate the risk factor, how much disease will decrease is population attributable risk. Next concept here, while we are discussing the formula, is absolute risk reduction and relative risk reduction. So here, look at this example. This is what you can study with an example. A study was conducted to assess the effectiveness of a new treatment for a particular disease. So for any study, we have 2 groups. You're going to have a control group and you are going to have an experimental group. Whenever you see such a question, what you have to do is find out 2 rates. You have to find the control group rate and you have to find the experimental event rate. So, control event rate and experimental event rate. Okay, whatever is the event, whether it's protective or causative. Okay, so I find the experimental event rate and control event rate. It's very simple. If you look at the formula, you'll get confused. Don't look at it. So what are they saying in control? That out of 120, there were 36 deaths. With the new treatment, what could they achieve? 26 out of 130. This is all you got to do. So what does this become? This becomes 3 out of 10. Whereas what does this become? This becomes 2 out of 10, right? So control event rate, experiment event rate. Now what are they asking? How many patients should be treated to avert a single death? This is what is called as number needed to treat. How many should I treat such that one death can be averted? So this is what is the difference. What could be the answer here? I have two rates, subtract them. So when you subtract them, this is called as ARR. Absolute risk reduction becomes 1 out of 10 and number needed to treat is 1 upon ARR. So it becomes 10. It's very, very simple, right? So when you see these numbers, just try to make up the formula. The only number you'll reach is 10, right? So 3 upon 10 minus 2 upon 10 and just invert it. So absolute risk reduction is control event rate minus experimental event rate, and this becomes 1 upon ARR. Okay, so this is what you have to do. Don't make any table. Not needed. You can just do it more simply. Fine. So this is what is the meaning of number needed to treat. Opposite can be number needed to harm. Let's say whatever treatment was happening was now harming, okay, or whatever the condition was, not the treatment, but whatever the condition was harming, the same thing. Just subtract the bigger number from the smaller number. You can't do it as minus anyways, okay. So that's all you have to do. So this is about number needed to treat. Now let's talk about screening, okay. Very, very important topic here. So in screening, same. 2 by 2 table is your starting point, and who comes on top? As we said, DD always comes on top. So disease is on top, and now here you have the test results. So if disease is there and test comes out positive, this is what we call as true positive. Let's call it A. If the disease is there but the test is negative, what do we call this? You are false negative. Let's call this C. If disease is not there but the test turned out to be positive, you are a false positive. Let's call it B. Disease is also not there, test is also negative, you are a true negative D. Right? So this is what we have gotten so far. Now, if you just know which formula is in which axis, everything is sorted. Here, you have sensitivity. So let's start off with sensitivity. So sensitivity, remember how to make a formula. If you learn how to make a formula, you will never forget. So this is where true will always be on top. True people are always more on top. Okay. So that is what you see. True is on top and then the other two sum. So true and then A plus C. So this is sensitivity. So can I say sensitivity is inversely proportional to false negativity? Yes, so N and N. Then what comes here is the specificity. So specificity, what would the formula now be? I have to bring D and B into the formula. D is true, so D has to be on top upon B plus D. So can I say now specificity is inversely proportional to false positive? Yes. What comes here is positive predictive value. So I have to bring A and B into the picture. Who should be on top? True should be on top. So A upon A plus B. NPV, true should be on top. So D upon C plus D. Right? So that's how it is. Don't make 4 formula ka line. Don't write it. Just remember where it comes and everything is sorted. If I also ask you what is the prevalence? So for prevalence, I know what is the disease. What is the disease? It's A plus C. So can I say this is A plus C upon the total population? So that becomes prevalence, right? So that is all you need. Now let's do the one-liners. Out of these, what is the ability of a test to correctly identify those with disease? It's the sensitivity. What is the ability to correctly identify those without the disease? That is specificity. True positive rate you want to remember is again sensitivity. True negative rate is specificity. Probability that a person who has positive result actually has the disease is the definition of PPV. Positive predictive value means if I've tested positive, what is the likelihood that I actually have the disease? And NPV is that if I have tested negative, how likely it is that I don't have the disease. Fine. Then we have two terms, pre-test and post-test. So pre-test probability is prevalence, right? Whatever is the prevalence is the pre-probability that you have the disease. It's the pre-test probability that you have the disease. After you have done the test, what is the likelihood? Is the positive predictive value. It is PPV. How I remember this is, it's in the name. Pre is prevalence, post is positive predictive value. Diagnostic power of a screening test is PPV. Okay, so that is what is defined as the diagnostic power. You should remember this sentence. Another sentence which has no meaning that you want to find is external validity of a study is an indicator of generalizability. Don't try to find meaning here. Just remember, it's not internal validity, it's external. If you want a mnemonic, there are two E's in external, two E's in generalizability. Okay, so that's how you will not confuse it with internal validity. So this is done. Now let's talk about series and parallel. What is the meaning? What is called as screening in series and screening in parallel? Let's say I do one test. Only people who are positive on this are allowed to go to the other test, and only when they are positive on both do we count that as a disease. So basically, to give you an example which you may not like, let's say I implement next. Okay, so in next they are planning that you will give one exam at the end of your final prof. Once you pass that, you will be allowed to become an intern, and after you do your internship, pass one more exam, and then you will get a seat. So now in this process, what will happen to the sensitivity? Overall, more people will get the seat or less people? Less people, right? Because now you have to clear two different exams in order to get a seat. So the sensitivity decreases. But can I say that people who are going to come out of it are definitely going to be good students? Yes. So this is what increases specificity. You want to remember sensitivity and negative predictive value always go together. So sensitivity goes down, so NPV goes down, SPR goes up, so P goes up. That's how you remember. Parallel, what do we mean by parallel? Parallel means I'm going to give you two exams. Okay, so at the same time there are two exams which are administered. You clear any one and we will give you a seat. So either one of them the patient results in a positive, you will be counted positive. So now more people will get selected because you have two chances. Yeah, so let's say instead of one NEET you are allowed to attempt two paper. Whatever is your better marks I will consider. It doesn't happen like that. But in that case, now the sensitivity increases, but specificity decreases, because now people who found one paper easier will also clear, right? So this is specificity decreasing. So when sensitivity increases, NPV increases and PPV decreases, right? So just remember these PP things go together and NN things go together. Next, so now we talk about these type of questions where they're going to give you a graph and they'll tell you what will happen to the cutoff if what will happen to the test results if I change the cutoff from point B to point A or anyways, you know. So what you have to realize that initially I've selected the cutoff at point B. So at this point, you are having these many people who are false negative. See this is true negative. So these are the people who are false negative. These are the people who are false positive, and this is true positive. When I change the result from B to A, what do we observe? That now whoever were these falsely negative people are going to become lesser. Yeah, so we are decreasing the number of false negative. So when you go from point B to A, the false negative decreases. False negative decrease matlab we know that it's inversely proportional to sensitivity. So sensitivity is going to increase, and you know when SN increases, NPV increases, so specificity decreases, PPV decrease. So anything that they ask, we can do it just with FN. On the other hand, when you go from B to C, again what's going to happen? Initially this was the false positive. Now you can see that that number declines. So the number of false positive is going to go down. So from B to C, the false positive goes down. So how does that change things? So opposite, FP, SP. So SP increases, PPV increases, and what will happen? Sensitivity will go down, NPV will go down. So this is what you have to remember here. So now let's talk about clinical trials. Very, very important topic because this overlaps with pharma as well as PSM. So you get asked this question a lot, okay? So there are 4 phases to a clinical trial. The phase 1 is where you are dealing with healthy volunteers. This is where you don't have patients, you take healthy volunteers. And the main aim is safe. Is it safe? I want you to remember a mnemonic here. Swim, which is your one thing to revise. If you know swim, you know clinical trials. So S, phase 1 tells you, is it safe to use this drug? So this is why we are not taking patients, we are taking healthy volunteers, because we are assessing safety, toxicity, how the drug works essentially in a human body, that is pharmacokinetics and pharmacodynamics. And it is this phase which tells us about the maximum tolerable dose. Okay. This is phase 1. Phase 2 is where I want to ask, does it work? So for us to know if it works, we need to obviously take into account patients. So this is where we have a moderate number of patients. Here we check efficacy. Now this is something which is a little controversial. If they ask you, where do you first check efficacy, that becomes second phase. But if they ask you, where do you confirm efficacy of a drug, that is phase 3. But what if they ask you a simple one-liner, what is the efficacy trial? Now you will find different answers here in different platforms. What is a better answer becomes where you are confirming. So the phase efficacy trial then becomes trial phase 3. Okay, so just remember that this is the efficacy phase of the trial, which is phase 3. It's controversial. Okay, so again, don't ask this doubt, because I'm already saying that it will be given differently. Nobody knows the perfect answer. You can try to mark whatever you want. Okay, so phase 2 is, does it work, where we check efficacy, we check optimal dosing, and we check whether it has adverse effects or not. And this is the drug where maximum, this is the phase where maximum drugs have a failure in the phase, and the trial stops. Okay, so this is where if you don't find it to be working, why continue the trial? So this is where maximum drug failures in clinical trial happens. Phase 3 is where you do an RCT. Here you have to answer the question, is it an improvement over an existing drug? For example, I make a new antipyretic. I have to answer the question, is it better than paracetamol, which is the standard of care? If not, why launch a new drug unnecessarily? So in phase 3, we got to prove that it's better than the existing drug. For that, we do a randomized control trial. One group will take PCM, one group will take my drug, and then we assess. Okay. So this is where we are comparing. This is a trial which is a large phase of a trial where you have a large number of patients who are either in placebo group or basically the standard group and our drug group. If we pass this phase, the drug is going to get the certificate of a new drug application, and now the drug can be launched into the market. But it doesn't stop here. Can it stay? So this is where we have post-marketing surveillance. So M of post-marketing surveillance comes in, and we monitor the drug, and sometimes we may find these long-term rare side effects, and they are published as black box warning. Two examples of this: in antidepressants, there is a black box warning that adolescents and young adults who are taking antidepressants must be monitored very closely, because then they have a higher risk of suicide attempts. Similarly, another black box warning recently came up with Montelukast, where they said that there is a higher risk of depression in people who use this. So these, when these drugs have been used for so many years now, and then you find something as a delayed side effect, that's come as a black box warning. So this is where we remember swim. Is it safe? Does it work? Is it an improvement? Post-marketing surveillance. Phase 0 is something which is a pre-trial phase, as the name suggests. So this is something which is not mandatory. But if you want a very small number of volunteers, right? So here you take a very small number of volunteers. This is done for either a drug which is very, very toxic or very, very expensive. So before you launch this big trial, you want to check that, is it even efficacious? Is it so toxic that it kills people? Don't start the trial, right? So this is that phase 0 trial, which is referred to as a micro dosing trial, right? So you're just checking before you start a trial. Preclinical trial, don't confuse preclinical trial with this. Whenever we talk about animal studies, that's called a preclinical trial. If the name is clinical, it's human beings, right? So phase 0 is not animal studies. A lot of students make this mistake. Okay, so this is what we need to know about trials. With this, we now go into biostats. So we're going to start off with the very basics, that is the type of data. So when we talk about types of data, there are 4 kinds of data. Okay, so you can remember NOIR here. The first one is what we call as nominal data. When answering the type of data, ask yourself 2 questions. is this data in any particular order, and is there an interval to that order? So nominal data means male, female, black or white, ABO. So things which have no order, no meaningful interval. This is what we also call as discrete data, right? So discrete data is usually nominal data, where it's either male or female. Yeah, there's no number to it. So this is nominal. O is ordinal data. This is also where you don't have a number to it per se, but it can be arranged in a meaningful order, but there is no interval to it. For example, TNM, T1, T2, T3, T4, it's in an order. Likert scale and Guttman scale. After any sort of a service, you will get this feedback out of 1 to 5. How was your experience? 1 was very bad, 2 was okay, 3 was good, 4 was very, very good, 5 was excellent. So this grade, it's in an order. So those are your Likert-Guttman scale and visual analog scale. You have seen this 10 phases of, from very, very happy phase to very, very sad phase with a lot of pain. So these are your pain analog scales. Again, ordinal. Temperature is where you have order and you also have meaningful interval, but there is no true zero. For example, in degree Celsius and degree Fahrenheit, you know that 35 is more than 36 and there's a fixed interval to that increase. But then there is no true zero. When you have that true zero as well, this is your ratio. So the former, where there is no true zero, that is temperature, this is what is called as interval data, whereas the last one, where there is a true zero, is R for ratio. So NOIR, nominal, ordinal, interval, ratio. Ratio examples being weight, BP, pulse, sugar, any number, right? So any continuous data for that matter, where you do have an order and you do have meaningful interval with a true zero. So the very basic things about types of data. Then we talk about our normal distribution curve. So as you can see, this is your Bell's curve, which represents a normal distribution or a Gaussian curve. Okay, so this is something which we don't normally see. This is a curve where you see that right in the center, you have every data is centered around this midpoint. So this is a very theoretical version which we don't see actually, where the mean equals the median equals the mode. So all of your central deviation measures are in the center and they all equal 0. Means everything is based around the midline very equally. Whatever is positive is equal to whatever is negative. This is what is called as a normal distribution. In a normal distribution curve, 68% of the population is covered in plus minus 1 standard deviation, 95% covered in plus minus 2 standard deviation, whereas 99.7 covered in plus minus 3 standard deviation. What will cover 100%? Never. When do we have 100% wound strength? Never, right? So the answer to 100% is usually never. Fine. So this is what we want to remember. If I ask you how much population is covered in plus 1 standard deviation, what will you say? You'll say 68, but it's not 68. Plus minus 1 standard deviation is 68. So if I say only plus 1 standard deviation, it's 68 divided by 2, that is 34%, right? So that's how they can trick you. Now, this is what are two curves. These are two curves which tell you skewed data. These are not normal, there is a tail. Whenever there is a tail, it's a skewed data. So look at the first one. The tail is on the right side. Now this is not radiology right left, this is human being right left, okay? So you can see that the tail is on the right, remember PR. So this is what is called as a positively skewed data when you have a right-sided tail. And look at this, there is a tail on the left side. So this is left-sided tail, which indicates negatively skewed data. Before I go to this point, there will be a question where they ask you, these are 3 points. Tell us what is mean, median, mode. Before that, I want to just talk about what happens, to skewed data and what are the 3 central deviation measures. So, out of this, what is the best measure of central tendency overall? That is mean, right? Mean is what is overall the best measure because it takes into account every single data point and that's why it represents the maximum. Best for nominal data, the best becomes the mode, right? Let's say how many boys and how many girls. What do you use? You count. Whatever is more is what is more. So that is mode, right? So there you're going to use mode. In ordinal, because you can arrange it in a sequence, I can take the midpoint and find that. So that midpoint represents the median. However, for metric data, always it's the mean that we should calculate. What is the most affected in skewed data? So let's say this is what my data set looks like, okay? By mistake, in the last part, I wanted to add a 4, but I added 400. Which is the one that is most likely to be affected? Obviously, the mean. The mean was supposed to be somewhere close to maybe 2.5, and now because of 400, it will be 399. So the most affected in skewed data is going to be mean. Least affected, who doesn't care? It's mode. Whether you add 400, 4,000, 40,000, 3 does not care. Mode does not care. It's the maximum in repeated value. So that is least affected. But does the mode really help me in this setting? Not really. So if they ask me most useful measure for skewed data, that's my midpoint, right? So even if this is skewed and I'm taking the midpoint, it'll still come out to be 3, right? So median is what is the most useful. So read the question very carefully in order to answer this. That least affected is mode, but then most helpful in skewed data is median. Okay. 50th centile is always median, right? Because I'm selecting the midpoint of the data set, right? So with this, now look at this curve. So first of all, can I say whatever is at the top is the unaffected one, and that has to be the mode. Okay, because that is the meaning of mode, the maximum repeated. Whatever is at the midpoint is always the median, because that is what it is. Whatever is most affected is the mean, and that's why mean will always follow the tail. Wherever the skewing is happening, the mean will be most skewed. So these are 3 concepts with which you will answer this question. Okay, then look at this curve here. So this is what we call as the scatter plot. So this is the scatter plot. Have we studied something similar in PATH, in HIMAT? Yes, we have studied flow cytometry. So this weird INI-CT question came. Somebody integrated PSM in PATH and they asked, what is flow cytometry an example of? It's an example of a scatter plot. So that is one thing. Now, coming back to PSM, the scatter plot gives me something which is called as Pearson's correlation coefficient. So this is the R that you see here. So this is the Pearson's correlation coefficient, and that is R. Okay. So here you have to be very careful and do not confuse this with odds ratio and relative risk. If you just understand that this is different, you will not go wrong. The students make a mistake here when they mix the concept of ORRR with correlation coefficient. So now let's understand what R means. So R equals 0 means no correlation. Now take the value. The value of R ranges from 0 to 1. Okay. The closer it is to 1, higher is the strength of the association. And the direction is independent. Positive direction matlab causative, negative direction matlab protective. So take the direction independent of the value. Meaning, if I say it is plus 0.4, it is weakly causative, weak positive. If I say R plus 0.8, closer to 1, it is strongly causative. Minus 0.4, minus matlab it is protective, negative correlation. Minus 0.8 matlab strongly protective. Understood? So take the value independent of the sign and don't confuse this with RR, because there RR equals 1 means no association. Here R equals 1 means perfect association, right? So that's just what I have seen students confuse. So this is all about these charts now. Looking at more charts. So now we are going to be focusing on the different diagrammatic representations. So look at this one. This is our traditional bar chart. Bar chart is the best for discrete data, right? So this is what we use for discrete data, like to represent how many males, how many females. If I have these multiple things here, so this is what is called as a multiple bar chart. You can see they are talking about the vegetables which are sold on day 1, 2, 3. So multiple things represented in this form. And if in one bar only you are representing 3 things, that how much production of oats, barley and wheat was in different years, this is called as composite or component bar chart. Okay, so these are the different bar charts. Then when we have continuous data means it's continuous. 160 to 170, 170 to 171 to 180. So it is continuous for numbers essentially. This is what is a histogram. So histogram is the bar chart for continuous data is what you want to remember. Same thing if I now estimate in the form of a curve and I take into account cumulative frequency. So this is where you can see that cumulative frequency is there such that towards the end you have maximum. This is called cumulative frequency curve. So obviously they'll not ask you cumulative frequency curve, they'll use the other name of this. The other name of this is ogive. Okay, so this is called as ogive. All you have to do is on the axis, if you see a cumulative word, it's ogive. Okay, next look at this curve. So this is where you are assessing the temporal trend. So this is what they'll ask to assess a temporal trend of a disease. What graph do you use? So we are seeing the number of COVID cases in February, March. This is a simple line chart or a line diagram. Okay, simple names we usually tend to forget. Okay, so that's why you pay more attention, because you'll dismiss this very easily in the exam, you'll not remember. Okay, then very important, this is what is a box and whisker plot. This is actually a box and whisker plot from my own thesis. So this is where we tested a new investigation called shear wave elastography. So we were testing that on different endometrial masses. So this is how we expressed our results. So how we express the result of box and whisker plot is, there is a box and there are two whiskers. This is where we divide the data into quartiles. What do you mean by quartiles? I'm sure you know what do you mean by percentile. Percentile is when you compare the entire population and divide them into 100 groups. If you divide them into 4 groups, that's called a quartile. So that is what it means. We divide the study sample into 4 groups. So 25% each. 50% comes inside the box and 25-25 on each of the whiskers. Okay. So this is how we make the box and whisker. So what should be this center part? This is obviously a normal distribution that I'm showing. Okay. So in the center, what you get is the median. Midpoint is always the median. So this is what an ideal box and whisker, a normally distributed box and whisker will look like. In real life, it's always skewed data, right? So you can see how we divide the 4 groups into quartile, and you can see that this is the median of this is the median of this. So just as a ballpark figure, you get to know that, okay, leiomyoma has the maximum variability, whereas the highest precision of the results came in, let's say, hyperplasia, because it's less distributed. So this is how we can say, different things looking at this curve. So now look at this. If I ask you, this is the curve, okay, how to say whether, or look at this, how to say whether this is right skewed or left skewed? We knew right and left. So what you have to do is make this sleep. Okay, so if this will sleep, it will look something like this. So again, do the same thing. Where is the tail? It's on the right side. So this is what is called as a positively skewed data. And you can see that this particular point in this place, somewhere close to 5, is going to be the median, right? So this is how we interpret a box and whisker plot. You are dividing your population into 4 data points. Next, you talk about this graph here. This is where you will see the word survival probability. Whenever you see survival probability, this is called as the Kaplan-Meier curve. Very, very important. This is usually used in clinical studies where you are basically trying to see how much a drug can increase the survival of the patients, particularly, in cancer studies. That's what we assess. So you can see how there is basically the survival probability at 35, let's say this is years, the survival probability at 35 years is much higher because of the group 1 as compared to group 2, where the survival probability is almost 0 at 20 years. So how much survival probability we could increase, we can detect on this curve. So you've had an INI-CET question on the same, interpreting the same thing. So if you look at the axis, you can just interpret it pretty simply, right? So this is Kaplan-Meier curve. This is called as Kaplan-Meier survival analysis. Next, what we are looking at is called as an ROC curve. Receiver operator curve. This is used for our screening test, right? We want to find the perfect balance between sensitivity and specificity. It's never going to be 100% for both. It can't be. So we have to find that perfect sweet spot where I can get maximum sensitivity and maximum specificity, and this ROC curve helps us do that. So what we have to plot is sensitivity on the y-axis and 1 minus specificity on the x-axis. So sensitivity gives me the true positive rate, whereas 1 minus specificity gives me the false positive rate. So this has also been asked, so you need to know the axis, true positive upon false positive or sensitivity upon 1 minus specificity. An additional advantage of knowing the axis here is you can also remember what is LR. LR is the likelihood ratio. Okay, so you can also know the formula of likelihood ratio as a free fact if you remember the axis. So likelihood ratio is sensitivity upon 1 minus specificity. Okay, so that also comes free with these axes. So how we select that cutoff is we have to find the test with the maximum area under the curve. So we plot the sensitivity specificity at various points and we select the point at which we will get maximum area under the curve, right? So you can see that we are measuring area under the curve. This is what an ideal test looks like, which has maximum area under the curve of 1 and you know it keeps decreasing. So this is what you have to just remember. ROC curve, area under the curve gives me the accuracy of a test. Now talking about this, so this was asked in one of the INICET exams. This is what we call as Ishikawa chart, also called as the fishbone diagram. And it tells us about the causes of a particular effect, right? So any effect will have multiple causative chain, right? So that is what we are basically trying to say, that any result is an effort of a lot of things, or any effect is a result of many causes. So if you want to describe that in a diagrammatic manner, this is the diagram. So this was just asked that which of the following will you use to demonstrate the cause effect relation. That was Ishikawa or fishbone diagram. Okay, then look at this. This is what is called as a tree plot. I've kept it on the side of stem and leaf precisely for the reason that I've seen students make this mistake where they think that stem and leaf together make a tree, must be the tree plot. No, both are different things. Okay, so tree plot is where I want to know the probability of multiple things. For example, if first toss, what is the probability that it will be head and tail? In the second toss, what is the probability? You know, so one after the other, if you want to know, that's tree plot. Whereas stem and leaf is just a lazy person in maths. Okay, so that is what it means. Here, what do? Let's say I have a data of 12, 18, 13, 19 and 15. So rather than writing this so many times, don't you agree that 1 to common hai? So keep 1 on the stem and plot the other numbers on the side. Yeah, so this is a lazy person doing math ka plot, which is stem and leaf plot. And then if they ask you this particular statement, the probability distribution that is used to show how many times an event is likely to occur over a specified period will not make sense the first time you read it. This is Poisson's distribution. In human being language, what this means is, let's say there is a trauma center and I find out that how many cases usually come on a weekend vis-a-vis how many cases come on, say, Monday. We will find that more cases come over the weekend to the trauma center because more people are outside their houses on the weekend, right? So this is what is called as a Poisson's distribution. So probability that is used to show how many times an event is likely to occur over a specified period. So I hope now this makes sense, right? So these are the various curves. Now let's talk about evidence-based medicine. So this is the pyramid of evidence-based medicine, and sitting right at the top is meta-analysis. So meta-analysis gives us the strongest evidence. Meta-analysis is a study of studies, right? So this is where you are comparing different studies on the same topic and presenting the data. That is what, without boasting, BTR actually is, right? I am trying to assimilate different sources and tell you, all right, this is the moral of the story. Now you can expand upon this or not expand upon it, is up to you, right? So this is what is meta-analysis. You are comparing different studies done on the same topic and then trying to show the cumulative results. So this is meta-analysis best. Then you have systematic review. Similar to meta-analysis, again you are comparing different studies systematically. Then comes critically appraised sources. RCT comes next, then cohort, then case control, and then case report series. And you can see that expert opinions are way down, right? So this is what you need to know. The first three have filtered information, where you have filtered the studies where the data is not correct. I'll show you how. So look at this. This is what we call as a forest plot. A forest plot is something that we do for meta-analysis. So look at this. We have accumulated these 5 studies done on the topic and we are comparing their results. Okay. So look at this. Smith et al. Showed that this is odds ratio, but look at the range. So now tell me, from what we have studied, is this study valid? No, we are saying 0.5 to 2.6 not valid. What about Jones et al? Again not valid. 1 is a part. So you are saying there is no association and then you are saying it's causative. Doesn't work that way. Similarly, not valid. So what did we do? We essentially filtered the 2 studies which were giving me the correct result, and I took an average of their results and I found the ultimate summary measure, that this is what the complete data on this topic is. Right? So this is what is forest plot. This is what meta-analysis does. So they asked you all of the following steps are used in a meta-analysis except. So we identify, yes, we select, we abstract it, and we analyze. So these are my steps of BTR also. We find different sources. We select information, go through notes of different sources. You abstract, right? You have to make it concise. It's not going to be presented in a concise manner. So basically you read from 4 different places and find out. I ask myself, okay, what is the common moral of the story which can be tested in the exam? You analyze it. But is there any randomization involved? No randomization involved, right? So you just ask yourself what goes into making any concise notes, right? What you do on your own as well. When you are comparing BTR, you are studying another RR, you are studying something else, you are doing MCQs, adding point onto this. What are you doing? You are conducting a meta-analysis of your own, and that's always the highest evidence. Okay. So this is what we know. Don't confuse forest plot with funnel plot, right? Funnel plot is what measures the publication bias. So I'll give you an example. Let's say we take into account any newspaper. If you look at any newspaper, what piece of news has the maximum space? You'll find that all of your masala news, political news will occupy the first page. All political fights will be on the first page. Let's say a farmer committed suicide. Where will that be written? That will be on one small box on the 6th page, which nobody wants to read, right? So is this a publication bias? It is a publication bias. What is correct news reporting or what is correct publication is you give everything equally. The public decides what they want to read, isn't it? So this is what is described by funnel plot, that what are you publishing? Are you only publishing positive effect size points or are you publishing everything equally? So this is what is a symmetric funnel plot. Whereas if you see this, जिसका भी effect size was negative, we see that those points are missing. They're only publishing positive effect size, masala news. This is what is a asymmetric funnel plot, or this is what indicates publication bias, right? So this is what you need to remember. Next topic, we talk about tests of significance. So here you have to start with the question that the data that I'm comparing, is it quantitative or qualitative? Other way of describing this, so this just doesn't mean numbers, okay? Don't just look at numbers. Quantitative data here or parametric data here means, are we dealing with mean, standard of deviation? If the answer is yes, how many groups? So if there are 2 groups, we do a t-test. If it is a before and after test, so sometimes it's a before and after test wherein same study group, let's say you would have seen Fair and Lovely ads. Before we were applying Fair and Lovely, I was so dark. Then I became very fair. So this is what is called as paired t-test. Same study group before and after. But if I am taking two different study groups, that's unpaired t-test. Three or more groups is ANOVA, called as analysis of variance, okay, ANOVA. Then when we look at qualitative or non-parametric, for example, there's a class, how many boys, how many girls? It will be proportion, 5% boys, 95% girls, right? So that's called as qualitative data. So don't just think ki number hai matlab quantitative, no. Whether it's proportion, the data type is what, okay? Numbers will obviously be there in both, so don't make that mistake. Now here you have to see the sample size. If it's a large sample size or a small sample size. Large sample size, we do chi-square. Even if you don't know anything, remember chi-square is the best for non-parametric. But for small sample size, we can do Fisher or Friedman. Apart from this, in non-parametric, a different way of asking you would be in terms of groups. So you can remember one group is McNemar, two groups are two words, chi-square, three groups are Kruse, Karl and Willis, three words, and ordinal is Wilcoxon rank. So these are a bunch of studies. You don't really have to memorize, just go through this once. In chi-square study, they might ask you something about degree of freedom. You just have to remember the formula is row minus 1 into column minus 1. If I tell you there are 2 rows, 2 columns, it becomes 1 degree of freedom. Okay, so 2 minus 1 into 1 minus 2 minus, फिर से बोल रहे हो, 2 minus 1 into 2 minus 1 becomes 1, right? So that is what you have to do here. So this is something which can be tested. Now look at this particular question. So there's a study conducted to test the efficacy of a new vaccine in preventing a particular disease in a population. The incidence of the disease before and after. First of all, are they checking a parametric value? They are. It's incidence. Before and after means what? This is paired t-test. So which of the following tests would you use? This becomes paired t-test. So as soon as you see parametric before and after, it becomes paired t-test, right? So that's how you have to approach this. So now let's discuss all of the formulae in one place, right? So we did one page of our epidemiology formulae and now we're doing one page of biostats formulae. In the end, you have to revise this, put this in your choti copy, revise it, okay? So this has been asked twice now. This is the formula of standard deviation. Just remember this. So here, this is what is the mean and this is what is the individual element, whereas n is what represents the sample size. So this is your standard deviation. Coefficient of variation is something that we are going to use to compare variation in two different studies. So this is where you take the standard deviation upon mean into 100. For example, two studies will be described where one's standard deviation is 2 and the mean is 10. Another one where standard deviation is 3 and mean is 15. How can I compare them? You will compare them using coefficient of variation to know the variability of two different studies. Okay, so variability of two different studies with two different data points we can calculate. Okay. What is variance? So variance is standard deviation square. Okay, it's the square of standard deviation. How to calculate sample size? Sample size, you want to remember, is 4 PQ by L square, where P is going to be the prevalence. So let's say prevalence is 50%. So P is 50 and Q becomes 100 minus prevalence. So this becomes 50, right? Or you can write it as 1 minus P. So then you can take it as 0.5 and 0.5. Fine. L is the allowable error. We are going to study this. If this is not mentioned, if they don't mention the allowable error, then take it as 5%. Okay, that's the P value that we are going to study. So normal allowable error will be 5% if not mentioned. So this is what is the sample size. What is the Z score? So Z score is for individual values within the sample, right? So let's say X is the observed value minus the mean upon the standard deviation. So you take your particular value, subtract it from the mean upon the standard deviation, and that gives you the Z score. We have studied this T score and Z score when you're talking about osteoporosis, right? So this is what the Z score represents. Confidence interval. This is very, very important. So confidence interval is mean plus minus 2 standard error. So what is standard error now? Let's say I did a study, right? I got a mean, I got the standard deviation. But this is the study. How do I generalize it to the population is called as the standard error. So I need to calculate the standard error of mean, and that represents the standard deviation for the entire population. So how do I calculate? You calculate it as standard deviation upon under root n. So let's take an example. This is where a study was done to find the average intraocular pressure. N is sample size, that is 400 people. Mean is given to us. Standard deviation was 10. So this is our study. They are asking us in what range will 95% population fall, right? So here we have to calculate the standard error of mean, which is standard deviation upon under root n. So standard deviation is 10, and what is under root 400? It will become 20, right? So 10 upon 20 becomes 0.5 millimeters. So my standard error is 0.5. So now what is the confidence interval? Confidence interval is mean plus minus 2 standard error. We know 95% population matlab 2 standard error or 2 standard deviation. So I have to multiply this by 2. So this is where the mean is 25. So 25 plus minus 2 into 0.5. So it becomes 24 to 26. If I had asked you 99% population, what would you have done? You would have done 3 standard errors. So then I will take 25 plus minus 3 into 0.5, which is 1.5. If I asked you 68%, you will say 25 plus minus 1.5, right? So 25 plus minus 0.5, basically 1 standard error. I hope this is clear to you. So confidence interval, unless mentioned otherwise, we take it 2 standard error. Standard error of mean, this is a very, very important formula that you have to remember. Similarly, this is just theoretical. Standard error of proportion will be PQ upon N. So this is where again P is prevalence or one proportion, Q is 100 minus the other proportion upon N. Standard error is inversely proportional to precision. Does that make sense? Lower is the standard error. Narrow is basically, narrower is your data set. Means you are more precise. Precise means more reproducible, more repeatability. So higher is the repeatability or precision. Lower is going to be the range of your standard error, right? So this is an important statement. Now let's talk about alpha and beta errors. This is again a topic where most students don't understand the concept here. So I'll try my best to explain, okay? So let's take an example first. First, let's understand conceptually and then we'll go to the theory of it. So let's say there is a drug that we have developed, okay? And now our drug is actually very good, but when I did a study, the study said that your drug is not good. So we did not launch it. Did we make an error? Yes, we made an error. Now, with this error, can I say that the general population was now deprived of a good drug? Yes. So remember this, the population was deprived of a good drug because of an error is beta error. Okay, error was there, but not a grave error. You just couldn't launch a very good drug. Yeah, so beta error. Now, let's say I made a drug. Let's say I didn't even make a drug. I just collected some carburin. Okay, and I said that this is my drug. And now my study said that, wow, what a drug. Your drug is very good. Launch it. So we launched it. Did we make an error? Yes. Actually, I had a very pathetic drug. But still I launched it because my study result was false. Now, is this a grave error? It's a grave error because now my population is drinking carburin thinking that they are getting treated. So this is what is the worst error. This is alpha error. So can I say the most dangerous error is alpha error, where your study said that your drug is good, but your drug was not good at all. And because now population is taking a bad drug. So that's what you have to remember as far as examples are concerned. So now let's see how this will be asked. Look at this question. A study finds no significant association between two variables, but truly there exists a difference. What type of error is this? What does this mean to you? In human being language, the study's way of saying that your drug is good or bad is saying that it has association, it has a statistically significant difference. So when we say that a study finds no significant association or no significant difference, this is study's way of saying that your drug is bad. but truly there exists a difference, but truly it is good. So now tell me, what does this mean to you? Our drug is actually good, but we couldn't launch it because study said it's bad and the population is now deprived. So this is type 2. Did you understand how to translate the studies language into human being language? That's how you got to do it. Okay. Apart from this, there is a 2 by 2 table. This is where we have to give a null hypothesis. A null hypothesis is something where you are gonna say the same thing but in a negative manner. Let's say you had a fight with your boyfriend, okay? So rather than saying I am better than you will say that you are better than me, but I will prove this to be wrong. Do you get it? So null hypothesis is saying that my drug is not better than the existing drug, but I will prove this to be wrong. So this is what null hypothesis means. So now look at this table. If the null hypothesis is true and you accept it, that's correct. If somebody is false and you reject them, that's correct. But if somebody is true and you reject them, that is an error, that's a bad error, that's type 1 error. So it's there in the name only. If somebody is true and you are reject them, that's type 1 error. If somebody is false and you accept them, that's type 2 error. Okay, so remember the words true and false. So this is second way of asking this. Third way of asking this is this table. Out of this, what is false positive error? So do you remember alpha fetoprotein? Do you remember alpha fetoprotein, a tumor marker? So now you remember alpha error is false positive, beta error is false negative. So these are the 3 ways in which they can ask you type 1 and type 2 errors. Fine. Which is the more dangerous one? As we established, it's type 1 error or alpha error, which is the more dangerous one. That's why we have to limit it. Before we start the study, we have to set a limit that alpha error won't be more than 5%. So we have to keep the probability. P value is the probability of committing alpha error to less than 5%. In other ways, I have to say that my p value should be less than 0.05. It means that the probability of committing an alpha error is less than 5%. Okay, so this is what is called as a statistically significant study. Otherwise, the study is invalid. Very, very important. So can I say confidence level, which is 1 minus p? My confidence level is more than 95% that I have not committed a mistake. Same thing. Power of a study is completely different. Power of a study is now beta error. So this is 1 minus beta is the power of a study. How do I increase power of study? One is obviously decrease your beta error. Yeah. Then you can increase the sample size or you can increase the precision. So 3 things: increase sample size, increase precision, decrease beta error. What is precision now? Precision is repeatability. Repeatability or reproducibility, right? Means how close is your data set. So precision, as we have studied, increases the power, and in the last slide we studied that it's inversely proportional to standard deviation or inversely proportional to the standard error. So that is what you remember, that precision changes 2 things. It changes the power directly, higher the precision, higher the power. It changes the standard error inversely, higher the precision, lower the standard error, right? Random error, remember what they do is they decrease the precision. So random errors decrease the precision. This is what is called as random error. Whereas accuracy is what is your validity of a study. Accuracy means how close you are to the actual value. So this is what is called as accuracy, and systematic error or bias reduce the accuracy. So there are 2 kinds of errors. Systematic error, as we discussed, is bias, whereas random errors. So random errors decrease precision, systemic errors decrease accuracy. So these are all the points that you need to know. I've tried to compile like everything from USMLE resources as well that you need to know here. Next, let's talk about sampling now. So very, very important and very easy. Okay, so you expect a question on this, methods of sampling. So look at this one. The best is simple random sampling. This is what is called as simple random sampling. What we do as lottery method, you take out random chits, every participant has a known and equal chance of getting selected. This is the best method where you randomly select the population. Simple random best. Then what you can do here, what is this image showing? This is what is showing a systematic randomization method. So here what you do is the first person is randomly selected and then you take up every third or every nth person. So you want to remember every nth person is selected, whatever it is that you decide. So this is systemic random. If you divide this population into strata first, you can see how now you have divided this purple and pink into different groups, and now here you are doing randomly. So this is where first you stratified. So this is stratified random sampling. Okay. What you see here is we have made clusters of different study groups and we are now selecting the entire clusters. So this is what is called as cluster sampling. This cluster sampling method is used to assess the immunization coverage. Okay, it is a method which was propagated by WHO to assess the immunization coverage. What we follow is this 30x7 cluster scheme. Okay. This is where you choose 30 clusters of 7 children each. Okay, so each cluster has 7 kids and you assess their immunization. So 30 clusters of 7 kids each. This is called as 30x7 cluster. The age group that you choose is 12 to 23 months of children. This is called cluster sampling, and here you want to remember that I am not assessing a lot of clusters, right? So to account for that loss of data, there is a mathematical effect that we incorporate that's called design effect. So design effect is used in cluster sampling to just account for the loss of data of the children we are not including. So remember these words together: cluster, 30x7, 12 to 23, design effect. Okay. Then look at these. So this is the first one, where you just chose the first 5 people you found, right? Whatever was convenient. So this is convenience. Yeah, in life it's always convenience over randomization. So this is what is convenience sampling. Look at this one. This is where now we are using our judgment now to decide who should be selected. So this is where the examiner uses the judgment to select the sample. Look at this one. This is what is called as a snowballing sampling, where you ask this one person, can you connect me to 3 of your friends? All right, so then we take them. Can you connect me to 3 of your friends? This is something that we can use if you want to test something like IV drug abuse, where people won't be forthcoming. So you ask this person, can you connect me to your druggy friends? So they'll connect. Okay, so this is called snowballing. What is this one, where now the patients are coming to you? So this is where you ask them to volunteer. So this is called as voluntary response sampling. So these are very good images which tell you, the different sampling methods. Moving on to the next topic. So with this we finish our biostats epidemio part. Moving on to the next miscellaneous chunks now. The first chunk is biomedical waste management, very important. What you need to remember here is the color coding. We start off with the smaller categories. So first we have red. So this is a plastic bag, red plastic bag, where you put stuff which is recyclable. R say red, R say recyclable, or rubber. So not technically rubber, but all of your tubings, right, come into red. So recyclable stuff like, say, vacutainers, syringes, Foley's, gloves, all of these things which are your latex things, red, rubber, recyclable, go into red bag. White is for sharps. How are your teeth? Your teeth are sharp. Your teeth are almost white. So this is what goes into white are sharps. So this can't be a plastic bag, right? So that's why white is actually this puncture proof container. It's a transparent container. I'm sure you would have seen this, the big plastic puncture proof box which is for sharps. Okay, so this is for sharps. Sharps like needle, a syringe with a fixed needle will go here. So needle, blades, right? Anything which is sharp. Blue. Blue is actually a cardboard box with a blue label. So if you are looking for a blue box here, you're going to miss it horribly. So you want to remember it's a white box with this blue label here. This is where you put glass. Very, very important. So all of your vials, empty vials are going to go here. Very, very important. What if they're broken? This is where students confuse. They think that acha, glass broken means sharp and they put it in white. No, any glass, broken or unbroken, is going to go into blue. Fine, that's what you want to remember. And implants, all of your orthopedic implants, prosthetic devices, pins are all going to go into blue. Okay. Yellow is also a bag. It's a non-chlorinated bag here. Okay. So this is the one which goes to an incineration plant. Okay. So that's why we don't want chlorine. Whereas these three guys here follow the 3R principle. 3R principle: recycle, reuse, reduce, right? So this is what we do in the ultimate thing. So now what all goes into yellow bag? So start off with human waste. Human waste, give an example, placenta, right? So placenta goes into yellow. Animal waste. So animal waste goes into yellow. Let's say you found a snake, you want to throw it, put it in yellow bag. But before that, identify. Okay, because we know how to identify. So first identify, okay, crate, and then throw. So human, animal. Then everything which is coming from microbiology. So all of your microbiological waste, very, very important. Vaccine, right? So if you have vaccine, let's say there is a glass vial with vaccine in it, where will you throw it? Glass or vaccine? Vaccine, right? You treat it as vaccine waste and put it in yellow. So all of your biochemical, microbiological, vaccine waste, your culture media, all of this is going to go into yellow. Very important, soiled linen, soiled gauze piece. So anything which has blood, mucus is going to go into yellow. Then you want to remember drugs. So cytotoxic drugs and expired drugs, they are going to go into the yellow bag. Fine. So this is what we need to remember as far as yellow is concerned. And all of your liquid, again, all of your liquid biochemical waste is going to be going into yellow. So just basically how I approach this is, remember red, white and blue, everything else is yellow. So let's look at a few examples and try to just finish this topic. Urine bag. Urine bag is going to go into red, whereas blood bag, soiled, so going to go into yellow. How to remember this? Cross mnemonic. Urine is yellow, goes into red. Blood is red, goes into yellow. Soiled gauze piece, anything soiled is yellow. Vaccine vials, vaccine, yellow. Cytotoxic drugs, yellow. Vacutainer, recyclable, goes into red. Gloves go into red. Whether soiled or unsoiled doesn't matter, go into red. Is little controversial. It's not controversial now, it's controversial since decades. When I was preparing, nobody had the right answer to this. It's always a difference of opinion. It still is. You are not going to find the answer to it. Just live with it. It's red. Okay. Expired drugs, yellow. Syringe, again recyclable, red. Syringe with needle becomes a sharp, isn't it? So it becomes white. Pacemaker or any implants, blue. Foley's, what is Foley's now? Foley's is again recyclable, and you know what they asked? Out of all of this, they chose to ask, where will you put plastic wrapper of Foley's? It's not a biomedical waste. Put it in black, okay? How do you treat mercury spill? So if there is a mercury spill, you have to take a cardboard and you take that mercury spill and put it in water. Okay, so you take cardboard and put it in water. This has been asked. Blood spills we treat with hypochlorite. So any percent they give between 1 to 5%, that's correct. You mop it with hypochlorite, which is a disinfectant, right? As far as COVID-19, they should still not ask, but they might. So all of these things are going to go into red. So the gloves, vacutainer, goggles, face shield, aprons and plastic overalls go into red bag, whereas mask, head cover, shoe cover, linen gown and patient soil go into yellow. So you can just remember, just go through this one time, right? So this is all about biomedical waste. Next chunk of information is going to be about demography. Very, very important. Now let's talk about the demographic determinants. So what are the 5 demographic determinants? First is birth, second is death, third is marriage, fourth is migration, so from one place to the other, and fifth is social mobility. Social mobility means movement across different castes, right? So these are the 5 demographic determinants. Now we talk about different formulae that you need to remember. So first we start to talk about crude birth rate. So what is the crude birth rate? The crude birth rate are the number of births upon the mid-year population. Okay, so the crude birth rate is number of births upon mid-year population. Mid-year population is considered as the population on the 1st of July. On a side note, you can remember 11th of July is the World Population Day. Okay, so this is World Population Day. Crude death rate are the number of deaths which occur upon mid-year population. Annual growth rate, remember, is birth rate minus death rate upon 10. This was asked in this FMG exam. Okay, so this is annual growth rate. The importance of the annual growth rate is, if the annual growth rate of the population is 1%, the population is going to double in 70 years. So if I ask you if the annual growth rate is 2%, when would it multiply? Not 140, it'll be half, right? So if it's double percent, it's going to double in 35 years now, in half of the time. So this is what is the Malthusian model. What is the dependency ratio? So the dependency ratio, who are the dependents first of all? So anybody less than or equal to 14 years, anybody more than or equal to 65 years are the dependents upon the mid population. So between 15 to 64 years, right? So this is what is the dependency ratio here. So this is what you need to remember. So ratio, right? The numerator is not a part of the denominator. Both are different. Literacy rate, who are considered to be literate? So anybody more than 7 years of age who can read, write or understand any one language, right? It need not be English, any language, upon the total population who is more than 7 years. So more than 7 years who can read, write, understand, upon total population more than 7 years into 100, right? That's the literacy rate. Talking about sex ratio. So sex ratio is female upon male, all right? So this is something which is the number of females upon number of males into 1000. The same for child sex ratio. You want to remember 0 to 6 year female upon 0 to 6 male into 1000. So this is what you need to remember. Now let's talk about the various survey systems in place in our country. So you need to know about census. So census, remember, is something which is done 10 yearly. The last census was conducted in 2021 and it's going to estimate almost all of the vital statistical data. What you need to know is about SRS. This is the sample registration system. Okay, so this sample registration system is going to get the data of crude birth rate, crude death rate. So sample registration system, crude birth rate, crude death rate, MMR, IMR. So this is going to get the vital statistics. This is called as a dual level study because you're going to take this at central as well as state level. Okay, so this is what is SRS. Here the data is collected 6 monthly, right? So the 6 monthly data is collected, but the report is published yearly. So just keep that in mind, that it's collected 6 monthly but published as a yearly data. Then you have National Family Health Survey. This was last done in 2014 to 2019. So this is a 5-yearly report which comes in and gives you statistics of all of the family welfare related stuff. Civil Registration Survey is what calculates the birth and death, and you have to remember that birth and death both need to be registered when? They need to be registered within 21 days, right? Registering the birth is the onus of the hospital, but registering the death is the onus of the family, right? So these are the data systems that you gotta know about. Now let's talk about the difference between eligible couple and target couple. So here you want to remember what is an eligible couple. Eligible couple means any couple in which the female is in the reproductive age group. So what is the reproductive age group of a female? Between 15 to 49 years. This is the definition, the target. Basically the eligible couple is the target where we have to provide them with contraception. So this is the group where we need to access them for contraception. Whereas a target couple is the couple who have either completed their family or have at least one living child. Okay, so completed their family and have at least one live child. This is our target for sterilization. Okay, so sterilization, permanent sterilization should be promoted in them. So this is what you want to remember, eligible versus target couple. So now let's start to talk about demography. So here we are talking about the demographic cycle. A lot of questions can come from this and it's a little tricky, but just understand it once and you'll remember. Okay, so the first stage of any population is where we are operating at a very high level of birth rate as well as death rate. In the second stage, when you have better healthcare facilities, what starts to happen is the death rate begins to decline. So the birth rate is still high, but the death rate begins to decline. So this is where the population starts to really grow, because now you have more elderly who are going to survive, right? So you can see that there is a rapid increase in the population. Stage 3 is where now family planning comes into play and even the birth rate starts to fall along with a low death rate. So this is stage 3. Stage 4 is the place where we want to be, where we are at a stable population where both birth rate and death rate are at a low. So this is very important, that from stage 1, which is high birth rate, to death rate, we eventually want to go to stage 4, which is low birth rate and death rate. Stage 5 is something we have not yet seen. We are all at stage 4. The developed countries are at stage 4. Stage 5, as is written, is yet to be seen, where the population may rise, may stable, may further decline. So this is what we need to see. So now what you have to remember out of these is what is demographic gap. So what you see in this figure as green, the difference, right, is the demographic gap between the birth rate and the death rate. So can I say that the maximum demographic gap is going to be at stage 2, where the birth rate is high and the death rate is starting to fall? And minimum demographic gap, you have to remember, could be stage 5, where theoretically we could be at a negative demographic gap where the population might just decline. Okay, so that's stage 5, but stage 5 is not in the option. Then we go for 1 or 4, where birth rate and death rate are at either a very high place or at a low place, but the difference is the minimum, right? So here you have to be very careful with the options. Either 5, if not there, then 1 or 4. Okay, so this is about demographic gap. India and China are currently in stage 3. Developing countries, are in the earlier stages. So stage 1, 2 or 3, where the population is rising or in early falling stages, whereas developed countries are in stage 4, and ideal is stage 4, where you are at a stable level with low birth rate and death rate, not stage 5. We don't want population to dwindle as well. We want it to remain stable, right? So that is what you need to remember. There are few more very confusing words. First of it is demographic transition. So the transition of a population from stage 1, that is high birth rate and death rate, to stage 4, that is low birth rate and death rate, is called as demographic transition. What is demographic bonus? So demographic bonus comes in stage 3, where the birth rate is low and the death rate is also starting to be low. Basically, it is the birth rate declining, and that basically decreases the dependent population. So this is where more youth is present in order to serve to the economy of a nation. So this is where we are saying that whenever birth rate falls, that's called a demographic bonus, because now more people are contributing to the economy rather than taking care of the dependents, right? So that's stage 3. And demographic trap is stage 2. where you essentially feel that, okay, my death rate is declining, so that's a good thing, but it's actually overall increasing the population. So that is what is referred to as a demographic trap, right? So these are a few confusing terms you want to understand. Now have a look at this population pyramid. You can get independent questions from population pyramid. So in the early stages, stage 1 and 2, you can see how this population pyramid is a pyramid, right? It's a triangular shaped curve. What you want to see, first of all, the population pyramid is an example of a double histogram. We studied histogram, right? This is where you are comparing the age also, you are plotting the age and you are also plotting the sex, right? Men and women. So this is what is called a double histogram. So in the early stages, you can see how it has a wide base. And a wide base is not a good sign because it means you have more dependents, you have more children. So this is what a pyramid indicates. Whereas in a good population, we will have this spindle or urn shape, and that is always good because now it says that this is your demographic bonus. This is your middle-aged population that is working and contributing to the economy, which is maximum, whereas the dependents are low. Yeah, so this is what we have to see in the shapes here. Now there is a box here comparing let's say there is a village. So this is where you can get numerical questions. So let's say there is a village where there are 100 live births. How many BCG vaccines will you keep? So this is where you need to know that for BCG, the wastage factor is 50%, or you want to remember the wastage factor is 2. Means I need to order double the vaccines, okay? So this is what is 200. So you want to multiply it with the wastage factor, which in this case becomes 2. How many pregnant females? For that, you just remember that 10% pregnancies get wasted, or in other words, they don't succeed. So 110, you just have to add 10%, right? So you consider 10% wastage factor here. I know not the best term to use, but this is how you want to remember. And how many minimum number of ANCs should be registered? So you want to remember at any point, minimum 50% of that pregnant female should be registered, right? So here in this case, it will be 110 divided by 2, which is 55, right? So this is what you want to remember as far as the numbers are concerned. Next, we talk about a few definitions. So here, you have to adopt a stepwise approach. One word and you have to recognize 4 definitions. First is GFR. GFR is gross fertility rate. Then you have total fertility rate, gross reproduction rate and net reproduction rate. Everywhere you keep adding one step. GFR is where you have number of births upon mid-year population of reproductive age group women. So simple. How many births per reproductive age group? In TFR, you further refine it and you make it sum total of age specific fertility rate. So the extra thing we've added here is ASFR, age specific fertility rate. GRR, the step up here is daughter. So you can see ASFR and now we are talking about daughters in GRR. NRR, one more step up. So you can see daughters, you can see ASFR, you bring in mortality. Net, right? So how many are left? Net reproduction rate is going to be minus the mortality. So GFR, just births, TFR, age specific, GRR, daughters, NRR, mortality with daughters, right? So this is how you will recognize these formulae. Out of all these, what is a measure of completed family size? That's total fertility rate. Target total fertility rate is 2.1. Okay. Best measure for impact of family planning, also TFR. The best for measure of growth of population is NRR, net reproduction rate, and the target NRR is 1. In other words, every female gives rise to one daughter, gives rise to her own replacement such that the population remains stable. And for us to achieve this, the couple protection rate must be more than 60%, means at least 60% of the population should be using contraception, right? So these are the numbers we have to remember. Now, let's learn all of the formulae. So now, do you want to learn formulae or do you want to learn how to make a formula? It's better to learn how to make a formula so that you don't have to burden your memory. So remember the standard prototype formula. Let's take into account IMR. So IMR is number of infant deaths upon live births. So whatever they are asking, whatever mortality is being asked, put that in the numerator upon live birth into 1000. If they ask what is neonatal mortality rate? So number of neonatal deaths, neonates are 0 to 28 days upon live birth into 1000. Early neonatal death, 0 to 7-day mortality upon live birth into 1000. Under 5 mortality rate, under 5 mortality upon live birth into 1000. Right? So you know how to make a standard formula. Now learn two exceptions. Maternal mortality ratio. This is where you have number of maternal deaths upon live birth. Everything is the same, just the multiplier now becomes per 1 lakh. So instead of 1000, the multiplier is the exception here, per 1 lakh. When we say maternal deaths, what do we mean? So maternal deaths are any death because of pregnancy related events. Okay, means if the death is by, say, electrocution, if the death is, say, by an accident, that is not included. So we do not include electrocution, you will not include accidents, right? So anything which is not because of pregnancy, do not include. And what is the timeline? Within 42 days, right? So within 42 days is what is included. So 42 days of delivery, that is included as maternal deaths. So this is maternal mortality ratio. What is maternal mortality rate? As we have learned, ratio means numerator is not a part of denominator. Maternal death, live birth. Maternal mortality rate means it's a part of the ratio. So this is where you have number of maternal deaths upon women in the reproductive age group. So this is where you have all women in reproductive age group, and now the multiplier goes back to being 1000. So this is what is maternal mortality rate. This multiplier can be given as 1 lakh also in certain sources. So you can just, see it. Both are correct. None of these is wrong, but it will be written per 1000 or per 1 lakh. Okay, so this is a little variable. So you just want to remember maternal mortality ratio is 1 lakh. Now perinatal mortality ratio. What is different here is the denominator. First of all, what does perinatal mortality include? Very important. It includes any death which has happened in a stillborn or a liveborn who is more than 28 weeks POG, or the weight was more than 1000 grams. Now this is the period of viability we consider in India. Overall, worldwide, the period of viability is now 20 weeks, but for all of our formulae purposes, you will remember 28 weeks, okay? So more than 28 or more than 1000 grams plus early neonatal deaths. So 0 to 7 neonatal mortality. So any live or stillborn death in this group more than 28 weeks POG or more than 1000 gram or 0 to 7 days upon total births. So this is where the denominator is total births into 1000, right? So this is what you want to remember here. Out of all of these, what is the most important indicator of health status of our country? That is IMR. Quality of healthcare delivery services, focus on word delivery, and that will tell you it's MMR, okay? And the combined peds and obs, can I say perinatal is a reflection of both obstetrics? So this death is obstetric, whereas this death is pediatric care. It's a reflection of both of them. So PNMR is a reflection of both, right? So these are the formulae with which you can be asked questions, and in the recent trend, they are asking a lot of this page, okay? Very, very important. Now talking about vaccines, extremely important. We'll integrate everything that we need to know about vaccines in the next 4 pages. So the first one is the National Immunization Schedule. So according to the NIS, at birth, we give OPV0 and Hep B0. So these are your birth doses. Hep B birth dose should be given within 24 hours and OPV0 should be given within 15 days of birth, okay? So these are the birth doses and we give BCG, right? Then 6, 10, 14 become very, very important. So this is where your pentavalent vaccine comes in. So what is pentavalent? It is your DPT plus Hep B plus Haemophilus influenza B. So this is the penta that we give at 6, 10 and 14. In addition, you are also going to give OPV at all 3 doses. As we discussed, it's OPV2. We have done the bivalent OPV switch, okay? So, basically 2 bivalent OPV. So, 3 doses of OPV and 3 doses of rotavirus. So, rotavirus is given at 6, 10, 14 as an oral vaccine. So, this is rota. Then talk about fractional IPV. So, fractional IPV we give 3 doses. One is at 6 weeks, one is at 14 and one is at 9 months, okay, along with measles. So, you want to remember 6 weeks and 14 weeks and one is at 9 months. So, that's FIPV. And pneumococcal is again 6 and 14, 2 pneumococcal doses. So, PCV1 is 6 and PCV2 is 14 weeks, right? So, this is what you want to remember. So, 6, 10, 14, pentavalent, OPV and rotavirus, and FIPV for 6 and 14 and PCV for 6 and 14, and another IPV is at 9 months. So, this story is finished. 9 to 12 months mainly MR is what you want to remember, and we already did IPV and we can give PCV booster here. JE first dose is at 9 months and JE second dose is at 16 to 24 months. Okay, so these are your 2 JE vaccines. And then it's all about giving boosters. What you want to remember in adolescents, TD, right? So this is important, 10-year and 16-year diphtheria toxoid. And in pregnancy, again, we give 2 doses of diphtheria 1 month apart. If the last pregnancy was within 3 years, then only 1 booster is needed. Okay, so this is all about the vaccines to be given. How to give, where to give, how much to give. All of this will be taught to us by our vaccine man. So what do we need to know about vaccine man? First of all, we need to know how he looks. So he has huge limbs, small body. What you will remember, the name of our vaccine man is I am BJ. You know BJ, right? You have seen him. You have shaken his hand and he did not let go. So this is I am BJ. What do we remember? This is right arm, this is left arm. So, I am BJ. IPV, MR, BCG and J. Here the J vaccine I am talking about is the live vaccine. Okay, so we'll discuss. So, I am BJ. Whatever is on top is given as an intradermal vaccine. In intradermal, the maximum dose I can give is 0.1 ml. Yeah. Everywhere else, it's 0.5. So, I don't have to remember everything else. It's going to be 0.5 ml only. So, we can just write it as a common thing. MR is subcute. JE is subcute. So, this is what we remember. Just a slight exception. So, as we can see, IPV and MR both are supposed to be given at 9 months, right? So, that's why I don't want to give both on the right arm of a baby. It will be painful. So, that's why the third IPV, which is your fractional IPV3, will be given on the left side, right? So, that's just the small exception. That third one, because I'm giving MR already on the right side, third one is on the left side. So, I am BJ. In the arms, we have intradermal subcute. So far, so good. This is very, very important and very useful. So, I am BJ. So, BCG and J live vaccine are on the left upper arm. Everything else is on the left anterolateral thigh. So, your pentavalent vaccine, your HIB or Hep B when you have to give separately will be here. In addition, the JE killed vaccine. Now, the recent updates, we have switched from JE live to JE killed. Okay, so JE killed now comes on the left anterolateral thigh. All of this is intramuscular, 0.5 ml, whereas pneumococcal is preferred on the right anterolateral thigh. Again, 0.5 ml intramuscular. Right, so this is what we need to remember. And then oral vaccines. So, what are the oral vaccines? So, oral vaccines will be OPV and rotavirus. OPV, you know, do boonde zindagi ki. So, these are 2 drops to be given, whereas rotavirus are 5 drops. Another thing to be given orally will be vitamin A. So, this is important. How much vitamin A is to be given? So, less than 1 year, we have to give 1 lakh international units, whereas more than 1 year, we give 2 lakh. So, the first dose is given at 9 months, and after that, every 6 monthly till 5 years, I have to give. So, now do some math. 1 is 1 lakh, and after that, for 4 years, I am giving 2, right? So, this becomes 16 units. Do you understand? 4 into 2, 8. 8 2s are 16. So 16 international units plus 1 lakh. So under the national immunization schedule, a total of 17 lakh international units are to be given to a child till 5 years of age. So this is vitamin A. So for 4 years, 2 times 4 2s are 8. 8 2s are 16 plus 1, 17, right? So vitamin A is 17 lakhs. So this is what you need to know as far as the vaccines are concerned. Anytime a child comes for vaccination, we will first give oral vaccine and after that you will give injectable. So the child becomes a little more comfortable. So oral followed by injectable, because if basically you inject him first, the child is going to cry and will not even accept orally, right? So first oral, then injectable. In injectable, what you have to remember, the order will be intradermal followed by subcute followed by intramuscular, because again the irritability keeps increasing, so we keep the easiest one towards the end, right? So this is what is important, and pentavalent particularly is very painful. So penta is at the last because the child might just cry a lot, okay? So this is what you want to remember as far as general concepts of vaccination are concerned. In surgery video, I told you the angles, if you remember. IM is 90 degrees, just like our suture needle, right? Subcutaneous is 45 degrees, just like Vire's needle, whereas intradermal was 10 to 15 degrees. So I'm not going to write that again because we have already discussed that. So this is the Mission Indradhanush program. It is basically to ensure full immunization status. So under Mission Indradhanush, we have 12 diseases which are covered. What 12? Don't memorize this. Just remember what all vaccines are we giving, okay? So start with Penta. In Penta, 5 diseases get covered. DPT, you are giving Hep B, and you are targeting Haemophilus influenza B. What else were we giving? We are giving rotavirus. We are targeting polio, right? So OPV, IPV gets covered, and we have added pneumococcal conjugated vaccine. So how many done? Plus, how can we forget BCG, right? Plus MR, measles, rubella. So these are the diseases. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 and 11. And for locally endemic, we are including J. So a total of 12 diseases, and you don't have to memorize. Just remember the vaccines mentally and this is sorted. Even electronic vaccine intelligence network is to manage the logistics, right? So this is just an electronic program where they see nationwide, you know, the stocks, etc., and how it's being transmitted. So this is the even network. All right. So this is about the relevant PSM part of NIS. Very, very important. Let's talk about delayed immunization. Until what time can we give these vaccines? Okay. So when I said it's only within 24 hours of Hep B and within 15 days of OPV, this is only the birth dose, right? Overall, in general, this is what you remember. All of these vaccines can be only given up to 1 year. Means, let's say an 18-month-old baby comes to me with no vaccination. I cannot give any of these. I have to start with these vaccines. So these vaccines can be given up to 5 years. So MR, vitamin A, OPV. Hib can be given till 6 years, DPT 7 and J till 15 years, whereas DT and TT we saw we are also giving in pregnancy. This can be given till any age. So this is what you need to remember about delayed immunization. Next, talking about open vial. Very, very important. Open vial policy means any vaccine that you have opened, if you follow the cold chain, right? We will see this cold chain being followed in vaccine vial monitor. So if your vaccine vial monitor says it's good, you followed the cold chain, you can reuse that vaccine for up to 28 days. But this is not applicable to these things. MBJ. MBJ, who is MBJ? So we know it is measles, BCG, J. If you know the concept, it's not that tricky. All of these are reconstituted vaccine. Any reconstituted vaccine we can't reuse. So with this we can learn the diluents also. So MR is distilled water. BCG, TB. TB is very normal for us, right? So remember, normal saline. And Japanese encephalitis is a special disease, so special solution. This is phosphate buffered saline. Okay, so these are the diluents. COVID, because it's a new thing, we don't really want to reuse. And yellow fever is also a reconstituted vaccine, reconstituted with a special normal saline. Okay, so these are your concepts of exceptions to open vial policy. If you just remember any reconstituted vaccine or COVID-19, we will not reuse and open vial policy does not apply. So this is what we need to remember here. Recent update now, I just read somewhere that rotavirus is back into an exception. So this is something which you can just remember, that rotavirus is also an exception to open vial policy. That's a recent update. Okay. Now talking about heat sensitivity. So how do we measure heat sensitive vaccines, whether they have been affected or not? So for that we use this VVM. VVM is your vaccine vial monitor. Okay, so this is your vaccine vial monitor, and this is going to measure the cumulative heat exposure. So this is not a one time but a cumulative heat exposure to the vaccine, and indirectly this is telling us about the potency. So it is indirectly telling us about potency, but does it tell us about efficacy? No, it doesn't tell anything about efficacy. Does it tell about expiry date? No, it doesn't talk about all of those things. Expiry date manufacturer will tell. How will VVM tell? Efficacy is intrinsic to the vaccine, not something VVM will tell. For vaccine vial monitor, the indicator is p-toluene sulfate. Nowadays, there is one more indicator that we are using, that is called diacetylene. Okay, so you can remember both p-toluene or diacetylene. And how do we read it? So these two, where the square is lighter than the outer circle, are good vaccines, can be used. If it is equal or darker, if the square is equal or darker than the circle, we can't use it. So this is what we need to remember about VVM, and this is useful for heat sensitive vaccines. What is the order of heat sensitive vaccines? You want to remember OPV is most heat sensitive, followed by varicella zoster, even though varicella is not a part of program, but it is heat sensitive. But if they give reconstituted, any reconstituted is far more sensitive. So overall, it's BCG which is reconstituted more than OPV is what you want to remember. On the other hand, for freeze-sensitive vaccines, we will use this test called as shake test. So once you shake the vaccine and it, sediments, it means that we can't use it. But if it flocculates, it's a good vaccine. So shake test is used for freeze-sensitive vaccines. And what are freeze-sensitive vaccines? You remember HD. So hepatitis B more than DPT is what is freeze-sensitive. So if you remember, basically that Hep B and DPT are freeze and OPV is heat, we can also remember this. So this is our ice-lined refrigerator. The trickiest question they can ask you is, how do you arrange? Now, why remember this with a mnemonic? Remember this with a concept. Whenever we are close, let's say you are sitting in an air-conditioned room, where is it going to be the hottest? It's going to be the hottest near the door, where the door keeps opening, and that's why hot air keeps coming in. Whereas it's going to be the coldest farthest from the door. Yeah, same way here near the door, this opens like this, not like our fridge. So here the hottest temperature is on the top, whereas coldest is down below. So where should I keep my heat sensitive OPV? Subse coldest area, which is the lowermost part. Whereas my HD, which are my freeze sensitive, I want to keep them near the door. Yeah, so this is where you have Hep B. Hep B is a part of Penta, and DPT, and then TD. So this is what you want to remember, and Rota, BCG and measles come in between. So you remember the order this way very conceptually, and we remember this order of freeze and heat also. Talking about vaccine storage. So what is the smallest level at which you store vaccine using this refrigerator, that is ice-lined refrigerator? That is PHC. So PHC is the smallest peripheral level at which we can store a vaccine, and this property of ice-lined refrigerator is that it only needs 8 hours of electricity. So this is made for India. Even if you have frequent power cuts, cumulative of 8 hours in 24 hours, if you can give it, it will survive. So this is what is the special thing. If we go to villages and sub-center, now you have to carry the vaccines from PHC, right? So vaccine carrier is used for vaccination in sub-center, whereas day carrier is used for vaccination in villages. So in villages, this day carrier will carry around 6 to 8 vials, whereas in sub-center, we will carry around 16 to 20 vials. So this box here can be shown. This is what is your vaccine carrier. Okay, so this is your vaccine carrier. You'll see these ice box placed inside, and that is where we carry around 16 to 20 vials. So this is what we need to know. Large ice-lined refrigerator and deep freezer is at a community health center or district, whereas a walk-in cold room is at a district, state or zonal level. And this thermometer that you see is what is called as a dial thermometer that can estimate the temperature of the refrigerator. Okay, so these are the questions relevant to the vaccines. Moving ahead to strains now. So first I'll teach you the strains and then we'll go through the types of vaccines. So the strains you can remember with these cartoons now. So BCG you can remember as BCD. So this is where we use Danish 1331 strain. Rubella is RNA 27/3 strain. Measles, in the name you can find Moraton, Edmoston and Schwartz. So that's measles. You just have to find this in the option, right? So go through this once and you will see it in the options. J. Now J live strain is SA1414-2, but the killed strain, right? So you can see here live is SA1414-2, killed is Nakayama Beijing or the Indian Kolar strain. So that's the killed strain. Chicken pox, you can remember chicken with an egg becomes Oka. So Oka strain, this has high chances of getting asked. Oka strain is for chicken pox or varicella. Dukoral, make it cholera. So that is Dukoral strain of cholera. While we are talking about cholera strain, you want to remember that cholera has two kinds of vaccines. Dukoral vaccine is your monovalent vaccine. This was asked in this NEET. Okay, so this is cholera O1. Whereas cholera O1 with cholera 139, this is what is cholera O1, cholera 139. This is what is your bivalent Shanchol or the new one Morquax vaccine. Okay, so Dukoral and Sanchol are the established ones. You want to remember Dukoral is monovalent, Shanchol is bivalent with these two strains, right? So this was cholera. Mumps is Gerillin, so you can remember Tom and Jerry, Jerry with swollen parotid, that is mumps. Rabies is Pittman-Moore strain, so pits on man after a rabid dog bite. And yellow fever 17D. So they think that this looks like yellow fever disease, so that is 17D strain. So this is also important, 17D. And do you remember Taurus bodies, right? So we had Taurus bodies in yellow fever. Fine. So this is what we need to remember about the strain names. What is more important are the types of vaccine. So all vaccines in this box are your live attenuated vaccines. So BCG, MMR, Rotovac, which is your rotavirus, is your live attenuated vaccine. Then you have J. As we said, SA1414-2 is live, whereas Nakayama Beijing and Indian Kolar are killed. So this used to be IMBJ, subcutaneous injection, whereas killed is intramuscular injection. Typhoral, again, typhoid comes in two patterns. One is the live attenuated. So Typhoral is your TY21A. This is the live attenuated vaccine which is given to older kids more than 6 years. 3 to 4 doses are recommended. Whereas the subunit vaccine is the strain typhoid V1, more than 2 years, 1 dose with booster. So this is something I'm going a little more in detail of vaccines because they've really asked a lot of questions this time. So 2 strains of typhoid. Typhoral is in older kids, whereas typhoid V1 is in more than 2 years. So this is your subunit vaccine. Typhoral comes as a capsule, right? It's a vaccine which comes in a capsule. Varicella, your Oka strain is live attenuated. OPV is live attenuated. 17D yellow fever live attenuated, and influenza is live attenuated. All of these are your killed vaccines. So rabies is killed. Cholera, as we saw, both of the strains are killed. pertussis killed Japanese encephalitis and IPV. What you want to remember about live attenuated are all of these are contraindicated in immunodeficiency and pregnancy. Two kinds of exceptions. Which immunodeficiency can I give live vaccine? So you want to remember, this is a repeat question. In complement deficiency, you may give live. Okay, so this is the only immunodeficiency where you can give live vaccine, that's complement deficiency. That's first thing. So all contraindicated in immunodeficiency but not complement mediated deficiency. All contraindicated in pregnancy except yellow fever. So yellow fever is the only vaccine that you can give in pregnancy. So two kinds of exceptions we have done here. Right? Very, very important. So these were your killed vaccines. Subunit vaccines are your capsulated. Do you remember from micro our Shin bacteria? So S. pneumoniae, Haemophilus influenza, Neisseria meningococcus. And you know from micro that we don't include the B strain, right? So B strain is not included, it includes A, C, W and Y. And now you shall also add with Shin that typhoid V1 is also subunit. And then you have toxoid, which is diphtheria and tetanus toxoid, and recombinant DNA vaccine is Hep B vaccine. So these are your strains of vaccines. This page is really choti copy. You have to add, particularly remember strains of three things: JE, cholera, typhoid, right? Then we go to some adverse effects following immunization. So toxic shock syndrome and thrombocytopenia both are linked with MR. Intussusception, I'm sure you know, is rotavirus. And Guillain-Barré syndrome was linked with influenza, killed, but this is something which has been disproved now. This is killed influenza. Talking about DPT vaccine, you want to remember the preservative. The preservative is thiomersal, whereas the adjuvant which increases the efficacy is A for L, aluminium hydroxide. Okay, so you can remember PET and ANA go together. So these are the facts about the vaccine that we have to remember. Lastly, because it's so very relevant, you need to know about COVID-19 vaccines. Don't know if they'll ask you now, but just to know the evolution, we need to know about these. So now we are starting with the COVID-19 vaccines. So here, these are the different variants or the way that these were formed. So the first one is basically Covishield. So this was the first vaccine trial that went underway. So this was the University of Oxford or AstraZeneca trial, where they had this ChAdOx1 viral vector. This is a very important name because that tells you it was chimpanzee adenovirus and it was Oxford trial, right? So everything is there in the name, and we have also learnt in micro that adenovirus is what is used as one of the most common viral vectors. Okay, so this is what reinforces that. So this is chimpanzee adenovirus. So what is this? Is adenovirus with the gene for the COVID-19 spike protein. So this is where they put the gene within the viral vector. Okay, so essentially the target of COVID vaccine is spike protein, and that remains true for all of the vaccines. So this is what is Covishield. Okay, now along with Covishield, you also want to remember that this is the same mechanism, that is the Sputnik vaccine, and also India's first nasal vaccine, which is called as Incovac. This is the nasal vaccine that was approved for less than 18 years adults. Okay, so this is Incovac, also works on the same principle. On the other hand, what is this BioNTech Pfizer/Moderna? So Pfizer and Moderna, both of these vaccines, what was the agent here? So this is also something where we used the spike protein, but now it was lipid nanoparticle encapsulated mRNA vaccine. So here, instead of having a viral vector, now we are directly taking the nanoparticle, which is lipid, so lipid nanoparticle encapsulated mRNA. Novavax and also Corbevax, both of the names which are ending with wax and wax, this is the one where you have synthetic nanoparticle which is coated with the trimer spike protein. Now you don't want to remember all of this, just remember spike protein and different variants we are taking. Okay, so this is Novavax and then Corbevax. So Corbevax, what is special is it is India's first indigenously developed receptor binding domain subunit vaccine. So both of these are your subunit vaccines, and then you all know Covaxin. So Covaxin is inactivated coronavirus, or basically killed vaccine, right? So this is a killed vaccine. So these are the different COVID-19 vaccines. Next, we talk about tetanus. So how do we have to deal with tetanus? Is you first have to classify patient and then have to classify the wound and add the two. So how do we classify patient? We classify patient into 4 categories depending on when they've gotten the vaccine. So A is who has completed his dose within 5 years. B is 5 to 10 years. C is more than 10 years, and D is unknown or not completed. So less than 5, 5 to 10, more than 10, unknown. Now you classify wound. Any wound less than 6 hours, clean, non-penetrating, negligible tissue damage. So your good wound, and this is your bad wound. So let's deal with good wound first, or let's deal with them together. So in both of these, when the patient is good, within 5 years you had the last dose, best part is irrespective of wound, don't do anything. B is where in both of these subgroups, so if your last dose was 5 to 10 years, just give one toxoid dose, right? So I don't have to memorize this. C is where the difference comes. So if it is a good wound, just give one toxoid. But if it is a bad wound, now this person will also have to take immunoglobulin. So if your last dose was within 5 years, great, go home, nothing to do. If it was 5 to 10 years, just take one dose. But if it was more than 10, now if you are a good wound or a bad wound, it will decide. Good wound means only one toxoid, but bad matlab one toxoid as well as immunoglobulin. And what about unknown? So obviously complete course and complete course plus immunoglobulin. So this I don't have to memorize. So C is where the difference comes, and that's all you have to take away, that only one or 1 plus immunoglobulin. Clear? So this is the management of tetanus. Next, we go on to management of rabies. Very, very important. So here, first of all, again, categorize the patient. Category 1 is just touching or licks on intact skin. For that, you don't have to take a vaccine. Category 2 is nibbling of uncovered skin or minor scratches. The buzzword to look out for here is there bleed or ooze? If they describe bleeding or oozing, that is category 3. That is very, very important. If it's category 2 without bleeding, we'll vaccinate and local treatment. But if it's category 3 where there is bleeding, transdermal bites, licks on broken skin, contamination of mucous membrane with saliva, or contact with bats. Now in India, this is question mark. Indian bats, they say don't transmit rabies, okay? So take it with a pinch of salt. Bats, maybe, they might not ask you this. So bleed or ooze matlab immediate vaccination, immunoglobulin and local treatment, right? So now let's talk about how to give the vaccine, how to give the immunoglobulin. You've gotten many questions from immunoglobulin. So we have 2 kinds of immunoglobulin, human and equine. Human rabies ka dose is 20 international units per kg, and equine I have to give more, 40 IU per kg. This is one immunoglobulin I don't give IV. So that's the first point, never give this IV. Most of this is infiltrated around the wound, okay? So most is infiltrated around the wound, remaining you can give intramuscular. So this is how you have to give this. This is to be given within 7 days of bite. After 7 days of bite, there is no point of giving immunoglobulin. Very, very important. And also you want to remember, this is only given once in your life. If you have another dog bite which also is category 3, you don't need to take. So only once you will get immunoglobulin. So what all points? We know the dose. How do we give it? Within 7 days, once a life. What do you do with local wound? So will you wash the wound under water? Absolutely. Will you clean it with spirit? Absolutely. Will you suture it? Never. So these are just logical questions that they will ask you. So don't suture, wash with water, wash with spirit. Now comes the third part, which is vaccination. So vaccination, there are 4 regimens. This is the best part where you see the number of letters, and those are the number of days that you have to give the vaccine for. Re-exposure, meaning you already have gotten a dog bite, you have already been vaccinated, one more time a dog has bit you. Now what are you going to do? Re-vaccination. So this is 0 and 3. pre-exposure, if you work in an animal facility or you're sure that once in my life a dog is going to bite me, you can already take the vaccine up front. So this is where pre matlab 3 letters, so 3 doses, 0, 7, 21. Most of the times the patient will come post exposure. So we have modified Thai cross that is now recommended. Previous one was SN. So if asked to choose, go for Thai. Thai has 4 letters, so 4 regimens, 0, 3, 7 and 28. But this is given intradermal and you give 2 doses every time. So this is a little dhoka for the patient. We say 4 times, but every time you're giving 2 doses. On the other hand, SN is 5 times. So 0, 3, 7, 14 and 28. And this is intramuscular, 1 dose each. Okay. So 5 letters, 4 letters, 3 letters, 2 letters. Best way to remember the doses, right? Just see the letters and this is done. So this is very, very important. Many questions have come from rabies management. So now we start talking about TB and HIV, right? So the next focus here are going to be to cover 2 diseases in an integrated fashion. So we talk about tuberculosis first and then HIV from everything, right? From path, medicine, radio, as well as PSM and pharma as well, right? So mainly PSM and pharma, but everything else a little bit, whatever we have not done so far. So National TB Elimination Program, this is the diagnostic algorithm. So here, who is a presumptive TB case? So presumptive TB case is anybody who has had cough or fever for 2 weeks with significant weight loss or hemopsis or any abnormality in chest radiograph. So essentially 2 weeks if you've had fever and cough, you should get tested. So what do we do? So here we do 2 things. Either we do a smear examination or you give a chest x-ray. So in smear examination, you want to remember that if your sputum smear comes out to be positive, straight up the label goes as microbiologically confirmed TB. But if smear is negative and chest x-ray is suggestive, or smear is not available and chest x-ray is suggestive, or if clinical suspicion is high, we don't stop there. The next test then becomes CBNAT. CBNAT is also done for your microbiologically confirmed TB. So, essentially you are doing 3 tests: smear, chest x-ray, CBNAT. Can I say that? Yes. So, either your suspicion is high and you are doing it, or you have confirmed it and then you are doing it. So, 3 tests are being used here. Let's talk about them. Sputum smear. How many samples do we take? We take 2 samples. One is the spot sample and one is the early morning sample that the patient has to come and give. The test should be done within 24 hours. So within 24 hours, the testing should be done of the sample when it's received. I've also taught you the Petrov's method. Do you remember sodium hydroxide for the concentration of the sputum? We have done this in microbiology. Okay, so remember that. Then we talk about CBNAT. CBNAT means cartridge-based nucleic acid amplification test. So essentially we are doing a nucleic acid amplification and the test comes under the name of GeneXpert. I'm sure you have heard this name, GeneXpert. So GeneXpert can be done in any sample, right? So it can be done on sputum, it can be done on an FNSE sample, on a biopsy sample. So any sample we can use for GeneXpert, which will also give you rifampicin sensitivity. So it also tells us about the sensitivity. The Indian version of this is TrueNat. So this is your TrueNat, which can give the results as early as 1 to 2 hours. So this can give us the result very, very soon. So this is what you need to know about the test. So we have done sputum, we have done chest x-ray, we have done CBNAT to confirm and to check the drug sensitivity. In addition, there are other tests. So what are the second line investigations? We can use liquid culture. So in micro, we had learned MGIT, which is Mycobacterium Growth Indicator Tube. So this is the best method for culture. The conventional method of culture we use was LJ medium. But LJ medium will take close to 6 to 8 weeks for the result. Your patient will deteriorate so much in that time that result comes. You don't want that. Whereas liquid culture is the gold standard and it will give you in within 6 days the results, right? So this is the difference between the 2 culture media. And you see something written as LPA. LPA is line probe assay. So this line probe assay refers to drug sensitivity assay. So these are for drug sensitivity. While we are talking about all tests, this also I have mentioned what is quantiferon gold. So this is your IGRA. What is IGRA? It is your interferon gamma
release assay that we are doing to check exposure, right? So this is the best test to check the exposure, and this is done on blood. It is only blood test, blood only test. Okay, so just to summarize, sputum smear, GeneXpert, which is CBNAT, TrueNat is the Indian version of that, liquid culture or LJ medium is the gold standard, line probe assay is for sensitivity, and quantiferon gold is IGRA to test exposure. This is a more better version of Montu, which is your PPD, which was also to test exposure. So these are all of the tests that we have up our sleeve. Apart from this, HIV, TB go together. So anybody with HIV will be tested for TB. Anybody with TB will be tested for HIV. So that's the next thing. So this is what they are saying. All presumptive TB have to undergo HIV screening. Now, if the patient is sensitive to the drugs, you start with your first line treatment, which is what it was always, 2 HRZD. So 2 months of HRZD, your first line ATT drugs, followed by 4 months of HRA. So this is your first line ATT that you have to remember. So now let's start talking about the pharma here. Let's start talking about these drugs. So out of these, who is mycolic acid synthesis inhibitor? We're talking about isoniazid, right? So isoniazid, the mechanism is mycolic acid synthesis inhibitor. It's a CYP inhibitor. The name has inhibitor in it. Then you want to remember it has 2 side effects. You can remember from the name itself. INH injures neurons and hepatocytes. Yes, so that's how you remember that it has neuropathy and hepatotoxicity. INH is a drug. Do you remember this is a ship drug? So this can cause lupus. Yeah, what were the ship drugs? Sulfa drugs, hydralazine, isoniazid and procainamide. So these are your ship drugs, out of which I is isoniazid. You also want to remember that all of these drugs are metabolized by acetylation. So now that will make a difference. If the person is a slow acetylator, what will they develop? How I remember this is, let's say there is somebody who is a slow reader. How much will they be able to read? This much. But if you are a fast reader, you will quickly read all 3 letters. So a slow reader will reach only N, right? So neuropathy is a manifestation of slow acetylators, whereas if you are very, very fast reader, you will develop hepatotoxicity, right? So this is how you can remember. And also sideroblastic anemia. Why? Because it can cause B6 deficiency. So this is very, very important. So CYP inhibitor, INH, name, lupus and B6. These are the side effects. Which drug is a fatty acid synthesis inhibitor? That is Z, pyrazinamide. Pyrazinamide is also hepatotoxic. In fact, it's the most hepatotoxic. It is also going to cause hyperuricemia. Very, very important. And this is the one which acts on intracellular bacteria. It's the only one which acts on intracellular bacteria. Then, who is the one which causes red-green color blindness? You want to remember this is ethambutol. Okay, I know it is ethambutol, but you will remember ethambutol so that you remember it has optic neuropathy, red-green color blindness, and the mechanism is arabinogalactan synthase inhibitor. And finally, we have rifampicin, which acts on RNA polymerase. R for R, it acts on RNA polymerase. It has the maximum CIDL action, and rifampicin, you know, is an inducer. And that's why when we are going to learn about ATT plus ART coexisting treatment, I'm going to replace rifampicin with rifabutin, because rifabutin is a minimum inducer and will not metabolize the ART drugs. 2 side effects, it causes pulmonary syndrome and orange urine. Orange urine, pretty famous, right? Then rifabutin causes pseudo jaundice. We learned this in dermat as well, and it can cause uveitis. This time question, INICT, hypothyroidism caused by ethionamide. Don't confuse ethambutol with ethionamide, right? So the first 4 are your first line, HRZD. Now we are on to second line. So ethionamide is hepatotoxic and can cause hypothyroid. Then 2 more second line drugs, QT prolongers. So this is bedaquiline and pretomanid. So bedaquiline and pretomanid, which are now becoming the first line for your resistant TB. You want to remember cause QT prolongation, out of which bedaquiline is an ATP synthase inhibitor, whereas pretomanid causes free radical formation which can attack the mycolic acid. Okay, so this can cause free radical mediated damage of the mycolic acid cell wall, right? So this is the mechanism of action of these drugs. In pregnancy, we modify the regimen a little bit. So what you are essentially removing here is pyrazinamide, and streptomycin obviously is contraindicated in pregnancy. Aminoglycosides contraindicated. So what we are giving is 2 HRE plus 7 HR. So this is the modification in pregnancy. And what is the definition of MDR-TB? It is what it always was, isoniazid plus rifampicin. But they have modified the definition of XDR. XDR is MDR plus fluoroquinolone or any group A drugs. So what are the group A drugs? So group A drugs, you just want to remember this. I have not included this in your book because you don't really have to memorize it. You just see this once, okay? So this is how we are going to design your MDR or XDR treatment regimen. You no longer have these plans that we follow. So this is what was the older plan. You can still use this, but what is essentially done is you include 3 group A drugs. So what are the group A drugs? These are your fluoroquinolones, bedaquiline and linezolide. So fluoroquinolone, bedaquiline, linezolide, and add to it either clofazimine, cycloserine or terizidone. Okay, so these are group B, and group C are your drugs which include your pretomanid and delamanid. You have PAS here, you have streptomycin, amikacin here. So these are your other drugs included in group C. So this is what we need to remember. Out of this, bedaquiline and pretomanid we said have QT prolongation. So just remember group A and that's sorted. Okay, so your fluoroquinolones, which is LNM, your bedaquiline and linezolide are group A, and when you develop resistance to them, that is what is XDR-TB. So it anyways includes, the definition includes fluoroquinolone, right? So you want to remember H plus R plus fluoroquinolone plus bedaquiline or linezolide becomes XDR-TB. Okay, the older definition also you can just go through because you don't know if you know more recent advanced than the examiner. So remember the traditional one also, that is MDR plus fluoroquinolone, that remains the same, plus second line injectable. So there you used to have kanamycin, amikacin, capreomycin. So both the versions we now know for XDR-TB. So H plus R plus fluoroquinolone plus, if they ask older, streptomycin. If they ask newer, group A. So group A means bedaquiline and linezolide plus fluoroquinolones, right? So this is how we remember the definitions. Contraindicated in pregnancy, as I said, it's gonna be streptomycin. That is the only drug which is absolutely contraindicated, but bedaquiline and pretomanid are also drugs which should not be preferred to be given because they have a higher risk than benefit ratio. So essentially these 3 drugs we don't want to use. In prophylaxis, there is a new update. Previously, we used to give isoniazid for 6 months. Now, we have given double drugs, so rifapentin plus isoniazid, and the duration decreases to 3 months and that too weekly, right? So, who are the recipients of prophylaxis? Household contacts, anybody on any immunosuppressant or anti-TNF, people undergoing dialysis or silicosis. So, anybody who is immunocompromised at a risk factor or contacts, okay? So this is what we need to know from the pharma point of view. So now we talk about the TB program. So this is National TB Elimination Program. You know we had RNTCP earlier. It was not meeting the target. So what did they do to rectify it? They changed the name of the program. So now it's called National TB Elimination Program and this is the symbol of it. What are the goals till 2025? So we want to reduce the number of TB deaths by 90%, whereas TB incidence should reduce by 80%. We want to prevent more deaths. The catastrophic cost, they say, should be reduced by 0. Just a factual question, the World TB Day is 24th of March. Okay, so this is what you want to know from the targets of the TB program. This is the other program, Pradhan Mantri TB Mukt Bharat Abhiyan. So this is the symbol for that, colorful 5 people in a circle. And you have this ICT enabled adherence system. So this is what is called as DOTS 99. Okay, so this is a recent update where as they keep taking the tablet, they have this phone number, right? When they open, it's like a game, you're gamifying TB treatment. So they have to give this call on the number. So, you will tell, okay, I've eaten this. So this is how, we ensure that they are compliant and adherent to the treatment. Okay, so this is DOTS 99. We also have what is called as TB Nikshay Yojana. So this Nikshay is essentially another platform where we are going to monitor the cases, right? So this is where using technology, we are monitoring the cases, we are seeing whether they are compliant or not, and monitoring logistics, etc. Another version of this is called as Nikshay Poshan Yojana, in which you are giving 500 rupees per month to every TB patient in order to help for their nutrition. And now you also have a Nikshay Mitra Yojana, where you can adopt one TB patient, as in not bring them home and adopt them, but you can adopt them and support their nutrition, etc. Right? So that is Nikshay Mitra and Nikshay Poshan and just Nikshay. So these are the few things about the updates in TB program. Going straight up to PATH now. So these complexes we have not talked about anywhere, so I'll just cover them here. Gone focus. So you want to remember, as soon as TB enters our system, where it's localized is around the middle horizontal fissure. So this is your horizontal fissure. So either the lower part of the upper lobe or the upper part of the middle lobe. This is where the TB first goes. So this is the primary focus. This is a subpleural primary focus that TB enters. So you want to remember, this is peri-horizontal fissure, right? If you have gone focus plus lymph node, that is gone complex, and once it becomes calcified, right, the sign of a good immunity is that we have calcification. That is Ranke's complex. So you can see this X-ray, you can see how there is this focus around the horizontal fissure. You can see these white lymph nodes. These indicate that these are calcified. So this is called Ranke's complex. In fact, even in this gross image, can you see this subpleural focus here, which is white? So this is Ranke's complex. It's a calcified focus. Simon focus is in the apex. Okay, so do you remember Simon? Go back from your geography. So go back where? Go to apex. Okay, so that is Simon focus. Then you have Puls and Assman. One is supraclavicular, one is infraclavicular. Vowels stick together. So Assman is infraclavicular, whereas Puls is supraclavicular. Cement is liver focus. Rich, you become rich from your brain, right? That's what you want to remember. So rich is meningeal focus, whereas Wiegert is a focus in pulmonary veins. Weird, right? Weird Wiegert, pulmonary veins. Most common focus in congenital TB is again the liver. Okay, so this is also liver. So this is what you want to know about the focus. Now we talk about the infrastructure. Don't know how this question will get asked, but just have to know about this. So this is the infrastructure hierarchy. You have Ministry of Health and Family Welfare, Central TB Division, State TB Cell, District TB Center. What is most important for you is TB unit, which is below the district level. The population norm is 1 to 1.5 to 2.5 lakhs. So on an average, 1 in 2 lakh population. You want to remember these three staff present at the TB unit. One is the medical officer of the TB cell. You have STS, who is senior TB supervisor, and you have STLS, who is senior TB lab supervisor. So these people are at TB unit. You have district medical center, and you have your peripheral health institutes. So this is the infrastructure of TB. Just remember TB unit, and this is done. Moving on to HIV/AIDS now. So HIV/AIDS, first a little bit of microbiology. So you want to remember the proteins. This is very important. The envelope proteins are GP120 and GP41. So the main one is GP120, whereas GP41 is your fusion, right? It's your fusion entry. What you want to remember, that HIV/AIDS virus is going to use CD4 as the receptor for binding. So this is done via GP120, and there are co-receptors. So there are two co-receptors that they use, either CCR5, which is on macrophages, or CXCR4 on T cells. So this indicates early, whereas this indicates late. So can I say that if somebody has CCR5 mutation, this is a specific mutation described in India, you are going to be immune. So this is a mutation that confers you immunity to HIV/AIDS. Great mutation to have. So this is CCR5 delta 35. Then you can also see here there is P24, which is very, very important. This is the marker, the antigen that we can use for detection. This is the capsid protein. Okay, and you have reverse transcriptase here, which is going to convert the RNA into DNA. Which HIV strain is the most common in India? So you want to remember HIV-1 is more common. Here you have group and subgroup. And if you remember most common, you know the answer. Group M, subgroup C is most common. So this is what we need to remember. Now there are two mutations which regulate how fast or how slow the HIV will progress. So if you have HLA-B35, this is something which is called as a progressor. This gives you a poor prognosis and you will progress faster. Whereas if you are B27 or 57, B27 you know Angspont, right? So if God gives you something bad, He protects you from TB. So B27 was Angspont. So here you are going to control TB very well. So this group of patient is called a controller, right? So this is what you want to know as far as these extra H points are concerned. For acute HIV, right, there is a classification. Just to know the classification, that is called as Freiberg classification. Hasn't been asked and most likely will never be asked. But what if it gets asked? I will take party. So that is Freiberg classification. Here, this image shows you the detection methods, okay? So we can detect HIV RNA, but this is something we don't do commonly. So remove this. We can take P24 antigen. In fact, this is the earliest test that we can use for diagnosis. So this is P24. We can do ELISA, which will show us the antibodies. We can do Western blot, which will confirm the presence, right? So Western blot, you remember, Snowdrop. So this will detect the proteins, right? So this will detect Western blot. So this is what we can do. So now let's study the Indian perspective on this. How do we diagnose HIV/AIDS? So we use a battery of screening tests which are called as ERS battery, where E is ELISA, R is a rapid test and S is a spot blood test. So ERS is what we do. So this is what is written here. So ELISA, and these are rapid tests which may be done here. After the screening test is positive, we go for confirmatory test. So the confirmatory test that we use is Western blot. According to WHO, Western blot is not very good, but according to India, Western blot is the method of choice for confirmation. Okay, this is what we are using for confirmation. HIV DNA PCR is very, very important. This is what we will use for infant diagnosis, because there I can't rely on ELISA, I can't rely on immunoglobulins because maternal passage of immunoglobulins. So for infant diagnosis, we are going to do DNA PCR, and to assess response, right, to assess the viral load, to assess response to treatment, we are going to do DNA PCR. P24 viral antigen, you want to remember, is the earliest. As we saw, this is the earliest test that we do for an early diagnosis. So P24 early, DNA PCR for infant and response, and triaging, Western blot to confirm. Right. So now what you want to remember is, let's say blood donation. We are screening donated blood for HIV as we have discussed. Even if one out of these three is positive, right? We are doing a battery of 3. Even if 1 out of 3 is positive, you are going to discard this sample. If the patient is symptomatic, if 2 out of 3 are positive, we are going to send for confirmatory Western blot. For asymptomatic, all 3 have to be positive. Only then will you send for Western blot. This is how the diagnostic algorithm runs. For ANC, it is an opt-out test. Every ANC is made to undergo HIV screening unless she refuses to. That's called opt-out, right? Next, For HIV, now we are on to PSM part of things. So we are talking about NACO or National AIDS Control Program, where now our new target is 90, 90, 90. 90% people living with HIV know their status. 90% are on antiretroviral and 90% are virally suppressed. So this is the 90, 90, 90 target for NACP. 3 special schemes you should know about. All-in initiative is to target the increasing risk of HIV in adolescents. Nirantar scheme overall is to increase awareness of HIV. And Sunrise project is targeting the increasing incidence in the northeastern states. Okay, so I just feel you can get a question on one of these. Important. Let's talk about the efficacy and risk of transmission. Very important table. So if I ask you which route of transmission has the most common method of HIV transmission? So most common is sexual transmission. But which route has maximum risk of HIV transmission? That is blood, right? So don't confuse common versus risk. Highest risk is blood, and that's why we screen the blood before giving it. Needles have a 0.3% risk. So do we give post-exposure prophylaxis? Even for 0.3%? Yes, because if you are out of those 3 out of the 1000, you are going to get 100% HIV, right? So even 0.3% is very big risk for a disease like HIV. So everybody with a needle prick is going to get post-exposure prophylaxis. How is the post-exposure prophylaxis given? It is the same as first line treatment. So I will get to it, but right now only I'll tell you TLD. So TLD is the first line HART treatment, and it is also the first line post-exposure prophylaxis that we have to give. Post-exposure prophylaxis is to be started within 72 hours and it is taken for 28 days. TLD, tenofovir, lamivudine, dolutegravir. First 2 are 300 mg, last is 50 mg. Right? So this is out of the way. Needle prick, we have to give post-exposure prophylaxis. Vertical transmission, 30%. So let's talk about this now. So the maximum out of this happens during delivery. So how do we prevent mother to child transmission? Very important. So we were screening all mothers, right, during pregnancy. So if she is HIV positive pregnant female, now we have to start. If you have just diagnosed her, you have to start her on ART ASAP, right? Immediately you start her. Delivery, what is preferred? LSCS. The only little exception here that if a mother is very well controlled HIV AIDS, how do we define that? If the viral load is less than 1000 per ml, in that condition normal vaginal delivery may be allowed, but otherwise if simply asked, go for LSCS, right? Most important prognostic factor, so can I say, is viral load for mother to child transmission? Yes, it is. So now what do we do with a newborn who is born to a mother who was on ART with well-controlled HIV? They will get the best drug to prevent a mother to child transmission, that is nevirapine, for 6 weeks. But if it is a high-risk newborn where mother had uncontrolled HIV or wasn't on drugs, now we double the drugs and we double the duration. So you give nevirapine with zidovudine and now you make it 12 weeks. Okay, so double the duration, double the drugs. And we favor early infant diagnosis where at 6 weeks you start to do HIV PCR as discussed, early infant diagnosis, and if positive, start on ART. If negative, now you will screen the baby 6 monthly. Every 6 monthly you keep testing till 2 years. Okay, so 6 weeks and then 6 monthly till 2 years. So this is a very important table on mother to child transmission. Next, we talk about the clinical aspect of HIV. So there are 4 stages to HIV AIDS. Stage 1, what does it include? So this is the WHO staging, right? So this is what is the WHO staging. Stage 1 is asymptomatic or only persistent generalized lymphadenopathy. Stage 2 is where you have mild disease. So first of all, let's take into account weight loss. Weight loss 5 to 10%, more than 10%, or wasting syndrome. The definition of HIV wasting syndrome is more than 10% weight loss plus more than 1 month of any of these. So more than 1 month of diarrhea, fever or weakness. Okay, 3 things: diarrhea, fever or weakness. So that is described as HIV wasting syndrome. So this is the first way to diagnose. Then cheilitis, seborrhea, prurigo, herpes zoster, URTI, ulcer. So essentially local skin conditions are stage 2. Stage 3 are your conditions again which are superficial. So you have oral thrush, oral hairy leukoplakia, you can have TB now. Stage 4 is what we call as AIDS defining illness. So all of these become your AIDS defining illness. So you can see here how esophageal candidiasis is AIDS defining but not oral candidiasis, right? Then lymphoma, Kaposi sarcoma, PCP, or cervical cancer, cryptococcal meningitis, extrapulmonary TB, toxoplasma, encephalopathy and leishmaniasis. So these are your AIDS defining illnesses, right? So this is something which may be asked, just need to know about it. Now, how do we start treatment? So let's say we were doing ATT and ART basically. We were doing the checking of TB and HIV and both turn out to be positive. What will you start first? So first we have to treat ATT. We have to first treat TB. Why? Because of something called as IRIS. What is IRIS? IRIS is immune reconstitution inflammatory syndrome. Here what happens is your patient has poor immunity, right? Because of that, they are not able to fight against TB. Now, suddenly if I start ART first, now because of the immune reactivation, what you're going to have is your TB will flare up because now I produce cytokines, I produce granulomas, that TB will further flare up. So this is why you first want to kill your TB, right? So you first give ATT and then start ART. When do we start ART? We start ART 2 weeks later. So it's 2 weeks, but if it is a disseminated, complicated TB, then you start after 2 months, okay? So essentially, if they don't mention, say 2 weeks. So this is what you want to remember. So start irrespective of any clinical stage, any CD4 value. But if it is both TB, HIV, first start ATT, 2 weeks later start ART, right? And when both are together, replace rifampicin by rifabutin because rifampicin is an enzyme inducer, as we have already discussed. So this is what we need to know. A high priority TB HIV district is where the co-prevalence is more than 10%. So this is a repeat one-liner question. While we are discussing miscellaneous stuff, what about Hep B? So just to bring all post-exposure prophylaxis together, if the healthcare personnel is vaccinated for Hep B, check the levels. If antibody is more than 10, nothing needed. But if not vaccinated or less than 10, now give immediate vaccine and give him HBIG. So now you have to take the vaccine along with hepatitis B immunoglobulin. If antibody is less than 10, it's a little complicated, but just remember this, okay? Vaccine plus immunoglobulin. Keep it simple. So this is about Hep B. Just 2 extra things which I have added here, so you don't need the images. The images we have discussed, just write these extra points, okay? So here, what do we do about PCP prophylaxis, okay? So prophylaxis of your AIDS defining illnesses. So whenever you see this ground glass appearance, can you see the CT have its ground glass? And this is your GMS, gomorymethamine silver of bronchoalveolar lavage, showing you these black, this is what is described as these ping pong ball appearance or sickle cell appearance of PCP. So this is what pneumocystis jirovecii pneumonia will look like. So this is what we refer to as PCP. Okay, PCP is something that is not stained on gram stain. We have to do this gomorymethamine silver stain. How do we treat this PCP pneumonia? Remember the treatment, the drug of choice is TMP-SMX. This is the drug of choice for treatment. This is the drug of choice for prevention, which is prophylaxis. But if the patient has severe disease, which is defined as PaO2, if the oxygen saturation is less than 60 mm, also add steroids. Okay, so this is a little USMLE material, but you can remember that if there is hypoxia, add steroids. Prevention is with cotrimoxazole. And when do you start prophylaxis? So any CD4 less than 350. This is where PSM and medicine differ a bit. If you see medicine, they'll say 200, but we follow PSM here. You remember, anybody with CD4 less than 350, we have to start cotrimoxazole. When to stop? So this is when you can stop if the CD4 is more than 350 for more than 6 months. Okay, so more than 350 CD4 for more than 6 months, you can stop the prophylaxis, is what you need to remember. Talking about cryptococcal meningitis. So this we have seen in micro. These are your India ink staining, negative staining. So cryptococcal meningitis, how do we treat it? So you want to remember the treatment. We have also discussed this. The first line is going to be amphotericin B plus flucytosine. Remember, ampor and then flucytosine acts on nucleic acid. So you give this, and then the maintenance is on fluconazole. So fluconazole is maintenance. Prevention. Do I give prophylaxis? Yes. So fluconazole prophylaxis is given for cryptococcal meningitis to anybody whose CD4 is less than 100. So what all did we learn for prophylaxis? TMP SMX, CD4 less than 350, fluconazole to CD4 less than 100, and one more, we give macrolides, basically azithral, to anybody CD4 less than 50 to prevent against MAC, Mycobacterium avium complex. So these are the only 3 things you want to write in your book. TMP SMX less than 350, fluconazole less than 100, macrolides or azithral less than 50 to protect against MAC. These are the 3 prophylaxis given in HIV. Finally, bringing pharma here. So what are the drugs? So first of all, these are your entry inhibitors. We saw 120 is the most important, 41 is for fusion, CD4 is the receptor, and CCR5 is co-receptor. So first of all, fusion. 41 fusion, the name has infuviritide. 2 drugs which can be given orally have the letter O in them. So fostemsavir and maraviroc. And CD4 inhibitor is a monoclonal antibody. See Bali. You go to Bali, high chances you can get HIV. So that is ebalizumab. So these are your drugs. So attachment is maraviroc, which is CCR5. Penetration is fusion, that is enfuviritide. Then you have your reverse transcriptase. So you have NRTIs and you have NNRTIs. Okay. So these are what we will see in a while. You have integrase inhibitors, which are your gravis, and we have protease inhibitors. Protease inhibitors will need boosting with ritonavir. So ritonavir is a protease inhibitor only used as a boosting agent. So all of these protease inhibitors, as the name says, are CYP inhibitor. Now this ritonavir is such a good CYP inhibitor that people said, you leave your main job. Don't become protease inhibitor. You act as this inhibitor only. So they made it just a boosting agent. It left its main job of protease inhibitor, and now it's only supporting other protease inhibitor by acting as a CYP inhibitor and stopping their metabolism. Okay. Same cobicistat. So cobicistat is something that we use for potentiating gravis, right? Your integrase inhibitors, right? So this is what we need to remember. Now let's do the drugs. So you have to identify NRTIs from the side effects. So which one has maximum neuropathy? Stavudine. Neuropathy, if you have, you can't stand. Stavudine. Maximum pancreatitis? Didanosine. Remember, Dadaji died of pancreatitis. Okay, pneumonic. Bone marrow suppression and hepatotoxicity is zidovudine. Zidovudine, very, very important, causes anemia, bone marrow suppression, and it is hepatotoxic. And we also saw that zidovudine can lead to skin and nail pigmentation. Whereas what did we learn for palm pigmentation? Palm pigmentation was emtricitabine, right? So that was emtricitabine, right? So this is what we had done in dermat. Nephrotoxicity is tenofovir N. MI ka risk is with abacavir. Pigmentation palms and soles is emtricitabine, should have written here. Safest out of all of these is lamivudine. So lamivudine is safest. What are the drugs which can be used for both Hep B and HIV? These are your LET drugs. So this, be very careful. I'm not saying use it in coexistent HIV-B. I am saying these can be used in treatment of Hep B also and HIV also, right? So this is lamivudine, which can be used in both, emtricitabine, which can be used in both, and tenofovir, which can be used in both. Okay, in fact, tenofovir monotherapy is the first line for hepatitis B. Out of NNRTIs, we have two, which is the best to prevent vertical transmission. As we said, it is nevirapine, and the one which is teratogenic opposite. Teratogenic and causes vivid dreams is efavirenz. So, vivid dreams, VI. Out of protease inhibitors, few one-liners, minimum lipodystrophy is with atazanavir. Otherwise, these protease inhibitors have a lot of metabolic side effects. If you remember diabetes, we had studied in the list that they cause diabetes as well, right? But minimum is with atazanavir. Stones, indinavir stones. In fact, indinavir stones are the only stones which are even radiolucent on a CT scan. Okay, everything else is radio opaque on a CT. And it can cause jaundice, and intracranial hemorrhage was INI-CT question. This is tipranivir. So you can remember, tip, the blood will bleed. Okay, so that is how you will remember these anti-HIV drugs. Now talking about communicable diseases, essentially covering your droplet infections. Okay, so these are your airborne infections. So if asked to choose between airborne versus droplet, go for airborne. Okay, so we are talking about these diseases. Now they don't really ask you these incubation period, communicable period, but just to cover our bases, we are going to be talking about this. So how we want to remember the incubation period? Varicella 2 weeks, measles 2 weeks, rubella 2 weeks. So everything goes together. So obviously it's a range that you have to take, but if you remember 2 weeks, you have the best chance of remembering. Otherwise, you're going to forget the exact ranges anyways. Diphtheria is 2 to 5 days. So we retain 2, but we make it 2 to 5 days. So then you make the communicable period 2 weeks. Okay, something has to be 2 2 weeks. So this is what we make 2 weeks. The incubation period of COVID-19 is 2 to 10 days. And from this only remember communicability, 2 days before symptoms and 10 days after symptoms. So 2 days before, 10 days after is the communicable period. Whereas diphtheria is 2 weeks. Right? What about the other communicable period? So we had remembered 2 to 5 here. So now take that 2 to 5 to varicella. It means 2 days before the symptoms, 5 days after the symptoms. For measles, make 2 as 4. So 4 days before, 5 days after symptoms. Rubella, make it 7 days before, 7 days after. So, how do we remember these numbers? 2 week, 2 week, 2 week. Make it 2 to 5 days, 2 to 10 days. Give diphtheria 2 week communicable period and 2 day, 10 day for COVID. Then 2 day before, 5 day after, 4 day before, 5 day after, and 7 days. Other way is to not remember this at all, and that's also okay, but this is to cover all your bases. Now let's start talking about a few points of each. So varicella, we've discussed all of these, but just some PSM points now. So varicella, the most common complication here is pneumonia. One thing to remember here is that we give varicella immunoglobulin only. We do not mix vaccine with varicella immunoglobulin. They are not compatible together. So never give them together. We will give varicella immunoglobulin to whom? To susceptible population. This is to be done within 72 hours. Okay. So within 72 hours, and who are the candidates? Pregnant females, immunocompromised, or newborns whose mother developed varicella. So pregnant, immunocompromised, newborns are the candidate where you will give immunoglobulin, not a vaccine. Okay. Anybody else, you just isolate the patient, right? So that is what you want to remember. Only give immunoglobulin as a post-exposure prophylaxis and not the vaccine. So varicella vaccine not used for post-exposure prophylaxis. Live vaccine, we have already done OCA strain given as a subcutaneous. So this is not in our national immunization schedule, but given under IEP. Measles, it is single-stranded enveloped paramyxovirus. We have already done this. Most common complication overall can be otitis media, But the most common cause of mortality is pneumonia, and a delayed complication is subacute sclerosing panencephalitis, where they'll show you a child with delayed IQ. So this is a delayed effect, which is subacute sclerosing panencephalitis. The MR vaccine, as we have seen, is live attenuated IMBJ, so right arm subcutaneous, Edmundston Zagreb, and distilled water is the diluent. Okay. Rubella is following a seasonal cyclical trend, and congenital rubella syndrome, will have cataract. What else? You will have sensory neural hearing loss and patent ductus arteriosus. RA27 by 3 strain contraindicated in pregnancy. Very, very important. Diphtheria. This is where you get a lot of questions. So what do you do with a diphtheria case? You isolate them until they have 2 negative culture reports, macrolides for 14 days, and antitoxin, because ultimately it's the diphtheria toxin which is harmful. What they ask you is about the contacts. So you will definitely culture to see if they have gotten the disease. You will definitely give them macrolides, okay? And then what about the vaccine? For that, you have to know the status. If they have received less than 3 doses, then you complete their toxoid series. But if they have received more than 3, see when the last dose was received. If the last dose was received within 5 years, then you have to do nothing. You just give them macrolides. But if the last dose was received more than 5 years, it's an older sibling, then you have to give them 1 diphtheria toxoid dose. Okay, so that is where you will give them 1 diphtheria toxoid dose. Okay, so this is what we need to remember about contacts. Okay, so you will give everybody macrolides and you will culture, and depending on the last vaccine, less than 5 or more than 5, you give them toxoid. Okay, COVID-19 binds to ACE2 receptors. These are other receptors which bind to type 2 pneumocytes. So these are the relevant points you want to know about the other infections. With this, we finish the infections and the vaccine part. The next category is food adulterants, and then we go into programs. So this is a very, very important slide here. You at least get 1 question in every exam from this, so very, very important. If they describe this spastic paralysis developing in lower limb in an adult, think of neurolathyrism. So this is neurolathyrism. It happens because of boa toxin, which is present in kesari dal, that is Lathyrus sativus. So this is what this dal looks like. It can be used to adulterate any other dal. How to remove it? Banning crop, obviously. Steeping or parboiling, or vitamin C prophylaxis. Okay, so boa, kesari dal, Lathyrus. Next, if they describe non-inflammatory swelling of legs, diarrhea, cardiac failure, very, very important. This is epidemic dropsy. So remember, you drop dead if you have a cardiac failure. So this is epidemic dropsy. The toxin is sanguinarine, and this is basically the Argemone mexicana plant. So this sanguinarine mixed in mustard oil. This is the toxin in mustard oil, Argemone mexicana. So remember the row of plants that we had done in forensic. Just add 1 more to your mind, that is Argemone mexicana. Looks kind of like your yellow oleander, but it's not. Okay, so 2 different scenarios. Just remember that 2 yellow plants now you have in your head. So this is Argemone mexicana, and this can be tested nitric acid or paper chromatography. Okay, then you have endemic ascites. Endemic ascites will have ascites and jaundice, and this is happening because of these seeds. These are pyrrolizidine alkaloids, which are hepatotoxins, and they are called as junjunu or crotalaria seeds, which can be mixed with millets. And nowadays people are eating a lot of millets because 2023 was WHO's year of millets. So now you'll see everything, pasta, pancake, all is coming in millet variant. Okay, that's healthier. But then be careful of endemic ascites. Then in groundnut factory and all, because of the moisture, you can have Aspergillus flavus fungus, which produce aflatoxins, and you know aflatoxins cause aflatoxicosis, which can lead to HCC, right? So the way is to keep the moisture below 10%, control the humidity. So very, very important, page this one. Now talking about health programs. So this page is all your maternal and child health care programs. Okay. So the first one is Janani Suraksha Yojana. The aim of this program is to increase the institutional delivery. For this, we are giving cash incentive to both the mother and the Asha, and this is divided into rural or urban and low performing and high performing states. Okay, so this is the number. It's your wish if you want to remember. So Asha ka fixed hai, rural mein it's 600, in urban it is 400, whereas mother ka it depends 1400, 700 or 1600. Okay, I've seen students who just remember, like, tell me these 8 numbers in a row. So if you are at that state already, it's good. Otherwise, you can just, see this. So this is Janani Suraksha Yojana. Then you have JSSK. JSSK is Janani Shishu Suraksha Karyakram. So this includes both the pregnant mother and Shishu. Who is Shishu? He is your infant, or he or she are your infants till 1 year of age. Okay, so both of them, your infant and mother, both will get everything free. Free transport, free delivery cesarean, free drug diagnosis, blood transfusion. So anything that the mother or baby needs till 1 year is covered under JSSK. Okay. Then very important, I feel you can get a question on this, is PM SMA. So this is Pradhan Mantri Surakshit Matritva Abhiyan. Under this program, 9th of every month is a free ANC day. So any government hospital, you can go for a free ANC checkup. The pregnancy is triaged into 4. Okay. So green is where there's no risk factor. So that's easy to remember. Red is high risk, easy to remember. Blue is PIH. If you have hypertension, it will turn blue. And yellow are medical diseases, which are diabetes, thyroid and STDs. So blue, if you remember, everything else is yellow, right? So these are the color coding. Lakshya is your quality control, all with capital Q now, our quality control of labor room. So we're going to improve the quality of the labor room, and that comes under Lakshya program. You have Suman. Suman is Surakshit Matritva Ashwasan. Essentially, remember Suman. Initiative for zero. This is where you have zero preventable maternal and newborn deaths, and this is also taking into account postnatal. This is the only one talking about postnatal care till 6 months. Then you have PM Matru Vandana Yojana. This is somewhere 6,000, somewhere 5,000. So up to 5,000 to 6,000 cash incentive we are giving to pregnant mothers upon fulfillment of 3 conditions. So first is they have to do their ANC checkup, they have to come for institutional delivery, and they have to come for the 6-week vaccine. If they fulfill all 3 in installments, this cash is given. So they have incentive to come. So this is PM Matru Vandana Yojana. Ma is mother's absolute affection. So this is mother's absolute affection, and this talks about safe breastfeeding practices. Okay, so this is the Ma program, mother's absolute affection. And basically this is saying that exclusive breastfeeding must be given for 6 months, at least till 6 weeks this should be given if the mother is working, right? So exclusive breastfeeding, and begin breastfeeding within 1 hour of birth, and exclusive for first 6 months, and then start complementary feeding, and it's good to continue breastfeeding till 2 years. So this is what is the MAA program. Rashtriya Bal Swasthya Karyakram covers 30 diseases. Okay, so this used to cover 30. Recent update, it now covers 32 diseases. So TB and leprosy have been added to the list. So this covers these 4 group of diseases, which includes defects. Defects meaning congenital defects. You want to remember, it doesn't include congenital glaucoma. That has been asked. All are included except not congenital glaucoma. It includes deficiencies, but it doesn't include vitamin K deficiency or vitamin C deficiency. It includes childhood diseases, and it includes developmental disorders. Okay, so these are the 4 groups: defects, deficiencies, developmental disorders and childhood disorders. So just remember, no congenital glaucoma. That's the only question that has been asked. So this is what you need to remember for Rashtriya Bal Swasthya Karyakram. Next, we have the National Iodine Deficiency Disorder. So this is where you can see the symbol is the sun. Okay. So the target, the overall target is less than 5% goiter rate. So this is one impact assessment. Then you want salt uptake at consumer and manufacturer. So at consumer level, we want 15 ppm, whereas manufacturer level, we want 30 ppm. Another indicator here is urinary iodine excretion. Okay, so urinary iodine excretion, this is more than 100 microgram per dl. So two impact indicators, target goiter rate less than 5% and urinary iodine excretion more than 100 microgram per dl and 15 and 30 ppm of iodine. Four numbers from iodine program. Then SARS, this I'll also teach in pediatrics. SARS are the guidelines for childhood pneumonia. So these are an update to your IMNCI. So we still follow IMNCI, but you should just be aware that SARS essentially means lungs. So this is for childhood management of pneumonia. National Cancer Registry. So this was asked in this FMG exam as a one-liner. So you want to remember, in males, the most common is oral cavity, out of which lip is most common, more than lungs. Whereas they had asked in females, most common is CA breast, more common than cervix. Okay. Next, you want to remember PM Jan Arogya Yojana. So this is Pradhan Mantri Jai Arogya Yojana, which is your Ayushman Bharat scheme. This is very, very important. A lot of families are covered here, and this includes up to 5 lakh insurance per family without any limit on member, age or type of illness. Okay. Then you can see this green ribbon, right? Then you can see this green ribbon. This green ribbon is National Mental Health Program. Mental Act 2017 led to decriminalization of suicide. More on this I'll teach in psychiatry. What you can see here, this symbol of 3 people trying to catch a flower is what is your non-communicable disease program. So this is for cancer, diabetes, cardiovascular disease and stroke. These are the ones mentioned in the name. Okay, so now the name was becoming very long. So there are few more diseases which are included but not there in the name. So those diseases are COPD, CKD and also acute rheumatic fever. For acute rheumatic fever, I have told you in CVS, right? You remember the Vigyan mission mode. So now this has also been taken under the non-communicable disease spectrum. Okay, so all of these, cancer, diabetes, CVS, stroke, COPD, CKD, ARF comes under non-communicable disease. You can get an all except question here. Who is this? This is our mascot Sapna. Okay, so this Sapna is the mascot for leprosy. So this is the girl child, whereas Meena is the mascot, who is the girl child mascot for UNICEF. Okay, so remember Sapna and Meena. Sparsh is also one of the parts of the leprosy program. And then you can see 3 words written here: Nishchay, Nikshay, Nikusht. Nikusht, Kusht bimari matlab leprosy, right? So this is the leprosy software. Again for logistic, etc. This is the Nikusht tech that we have. Nikshay we saw was the tech for tuberculosis, right? How you can remember, Akshay Kumar has made probably a movie on every social issue ever except TB. So you remember the next movie of Akshay Kumar should be on TB. So Nikshay is for TB. We also saw Nikshay Poshan Yojana was 500 rupees nutrition to be given. We also saw the Nikshay Mitra Yojana, right, where you can support a TB patient. Nishchay on the other hand are your UPT. So these are your UPT kits that Asha can give to the villagers. Okay, so that's Nishchay. Sankalp is the booklet. It is the booklet which provides information on HIV AIDS, right? So that is Sankalp. Few more recent updates here. Muskan has a Q, just like Lakshya, this is also Q. So Muskan are your quality. This is also part of the quality assurance program where you want quality on child care. Okay, so this is where you are checking the child care services in the hospital. That is Muskan. Kiran is a helpline number for preventing suicides or for promoting mental health. So this is a free helpline number for prevention of suicides. Inspire is an acronym. When you expand it, it is essentially to decrease the risk of child abuse. Manas is also a program for mental health awareness. Manas, you can remember as mental health awareness. Another update on the Q series. So this Sa Kushal is essentially to check the healthcare services. So this is where we are checking the quality of the healthcare services and taking patient feedback into picture. So 3 quality assurance programs: Lakshya, Muskan and Sakushal. Okay. Kayakalp awards are also for the same, to improve the hospital, services, improve services. So they are awards based on that. So these are all the recent advances covered in one. And finally, the 3 most confusing things ever: Ujala, Ujjwala and Ujjavala, which happen to be 3 different programs running in the same country, so under different ministries. So how you remember is, as the size of the spelling increases, the seriousness of the issue will increase. Okay. So Ujala, smallest name, is for LED, affordable LEDs. Ujjwala is for safer fuel, little bigger name, safer fuel. This is Ministry of Petroleum. Ujjavala is the biggest name, biggest issue. This prevents human trafficking. Okay, so LED, fuel and Ujjavala. So this is all about the programs that we needed to know. More programs now. So this page is essentially for your nutrition things. So now talking about Poshan Abhiyan, right? So this Poshan Abhiyan, this is the symbol which is like a tree. So this is PM's overarching scheme for holistic nourishment. This is by the Ministry of Welfare and Child Development. This is what wants to make malnutrition free by 2022, which is already passed. So here the targets are, you can remember by SULA. Okay, you can remember SULA and nutrition go together. So this is SULA. So what you want to remember? Stunting, underweight and low birth weight. These 3 we want to decrease by 2% per year. Whereas anemia, we want to decrease by 3% per year. So you'll remember SULA: stunting, underweight, low birth weight, 2% per year, and anemia 3% per year. So this is Poshan Abhiyan. But what is Poshan Shakti Nirman? Is what is the refined version of midday meal. Midday meal was not working. There were a lot of reports that is adulterated food, low quality food. What did they do to improve? They changed the name of the program. So now it is called PM Poshan Shakti Nirman. This is under Ministry of Education. This is gonna target your government schools. So what all sections? So primary and upper primary, government aided Anganwadis, Madrasa and Maktabs. So this is what comes under Ministry of Education, and this is their target, that this much RDA we should meet. So caloric requirement 1/3 and half of the protein, which comes out to 450 in primary and 700 in upper primary and 12 and 20. So you can at least just remember 1/3 and 12. On the other hand, ICDS, right, Integrated Child Development Scheme. This is the symbol. So as this shows mother and baby, this is what is targeting mother and baby. Hence, this is coming under Ministry of Welfare and Child Development. So Ministry of Women and Child Development. So this is where we are targeting women and child. I misspoke as welfare earlier. It's women and child. So here the target group is going to be 0 to 6 years children, pregnant and lactating females, females in reproductive age group, so 15 to 49, and 10 to 18 adolescent girls. So essentially every child till 6 years and women starting from 10 years. Can I say that? So 10 to 18, 15 to 49 and pregnant lactating. So here we will take care of the supplementary nutrition, immunization, health checkup, education, as well as preschool, non-formal education of the kids. Same, the requirements to be met are 1/3 caloric, half protein. So you can remember, just see these values once. So these are your nutrition programs. Talking about Anemia Mukt Bharat. So this is the 6x6x6 strategy, as in 6 beneficiaries. Can you see this? 6 people screaming out for blood. So these are the 6 beneficiaries, and what is the dose you want to remember here. So these are your 6 beneficiaries: 6 to 59-month babies, 5 to 9-year children, 10 to 19-year adolescents, reproductive age group females, and pregnant lactating. You will remember 6 numbers. So you remember 20, 40, 60, just make 40 to 45. So 20 mg, 45 mg, 60 mg. Folate is 100, 400, 500. So folate is 100 microgram, 400 microgram, 500 microgram. In babies, we give this as bi-weekly. In pregnant lactating, it's OD, as you would have guessed. Everybody else, it's weekly. So this is how you will remember the frequency. In 6 to 59 months, it's a syrup. Pregnant and lactating is your main group, right? It's your target group and reproductive age group female. So in all of these, it's a red tablet. Children, we want to give something cute, so we give them pink tablets. Adolescents, you want to give them something cool, so you give them blue tablets. So this is the color coding that is done for all of these groups. So you remember 20, 40, 60, 100, 400, 500, right? So that way you can remember. Talking about reference man and woman, first of all, what's the definition? 19 to 39 years, so young adults. Reference man, the weight is 65. Reference woman, the weight is 55. Height 177, 162. BMI for both should be the same, 18.5 to 22.9. How much is the requirement? So you will remember three set of numbers, 25, 2100, 2700, 3400, depending on their lifestyle, sedentary, moderate work, heavy work. Now what you have to do, for a woman, take 3400 here and divide it by 2. So this becomes 1700, and then just take these two. So 25, 2100 and 2700. Clear? 21, 27, 34. 34 divided by 2, 17, and 21 and 27, right? So this is how you remember these values. BPL, what is below poverty line definition? So in a rural setup, if you can't afford to get 2100 kilocalories per day, or in an urban setup, you can't afford to get 2400 kilocalories per day, this is what is defined as being below poverty line. The definition of below poverty line, you want to remember, in rural setup, if you can't afford to get 2400 kilocalories per day, in urban, because in urban it's more expensive, so 2100 kilocalories per day, that is below poverty line. Talking about iodine requirements, so in a child it's 90 microgram per day. Now there are requirements for everything which have been listed as tables, but how are you ever going to remember that? So remember the most important ones. So 90, adult is 150. In pregnancy, they have asked, pregnancy is 250 micrograms per day, whereas lactation, it's going to be 280. Okay, so lactation has been asked. So you want to remember 90, 150, 250, 280. Fluorine, what is the definition of dental fluorosis? It's when the amount is more than 1.5 ppm in water, or it will lead to crippling skeletal fluorosis at more than 3 ppm. This skeletal fluorosis is going to present as increased bone density. And do you remember the interosseous membrane ossification? So that starts to become calcified or dense, okay? And dental is your teeth become sclerosed, okay? So there is dental fluorosis, yellowish or brownish teeth they can show. So this is what we need to remember. Talking about growth charts, you have had questions from the same. So this is the WHO multi-center growth reference studies where many countries were part of it and India was one. Here you need to know the three zones. Green zone is where a child will be there if their weight is between +2 standard deviation to -2 standard deviation, and this is what is called as road to health, right? So what do you want to do? Nothing, just let them be on that road, okay? So you don't want to do anything. Yellow is the zone where it is between -2 to -3, means the child is underweight but not severely underweight. So this is -2 to -3. This is where you will counsel the mother for home nutritional management, better food for the baby. Whereas in red, when you are -3 standard deviation, now we have to refer. Where do we refer? What is the first referral unit? That is community health center, because that is where you have a pediatrician, right? So this is where you will refer. So this is what we need to know for the growth chart. This question has been asked. Now, the next two slides, we talk about all miscellaneous stuff from environment chapter. So water, air, soil, etc. Starting with water first. So three instruments. What is this? This is Horrocks apparatus. So this Horrocks apparatus is used for knowing the chlorine demand. Okay, so you can imagine a boy called Horrock who has a lot of demands. Okay, so Horrocks apparatus, chlorine demand. You have these 6 jars and you take your water and you put this solution here. Wherever you have the color change, let's say third one, that nth one will tell you the amount of chlorine. So what you want to remember? N, whatever was the jar, into 2 gram is the amount of bleaching powder needed for 455 liters of water. Okay, so this is how they calculate chlorine demand. This particular instrument here gives, it's called a chloroscope, and this gives you the value of residual chlorine in water. Whereas this yellow and red things here is your OTA test, orthotoluidine and arsenite test, and this gives you both. It gives you free plus combined chlorine, right? So free plus combined chlorine. So these are your 3 water things. Let's talk about chlorination. So disinfecting action of the bleaching powder actually comes from hypochlorous acid. The contact period should be for 1 hour and the residual value 4 numbers. Drinking water 0.5. Post disaster chlorination is the most effective strategy, so we increase that. Swimming pool is 1, and that's why swimming pool water, if you've ever tasted, is more pungent, and we say that it's very rich in chlorine. It's because it's double of what we are used to, and to kill cyclops it's 2 ppm, right? So this is about chlorination. Few more water questions. So hardness of the water, you want to remember, temporary hardness is because of bicarbonates. So that's calcium and magnesium bicarbonates, whereas non-bicarb leads to permanent hardness. So this is where you may have phosphate or sulfates which come in, and the maximum hardness level which can be tolerated is less than 150. So you remember 150 ppm per mg per liter is the maximum hardness level that can be tolerated. Bacteriological indicators. So the best test to confirm fecal contamination, you want to remember, is E. coli, because E. coli comes from fecal matter. Recent contamination will be strep, fecal strep, and remote contamination is Clostridium perfringens, right? So 3 things. Best to confirm: E. coli, recent, strep, remote, Clostridium. Okay. Then 4 diseases. Water-borne diseases are diseases that are transmitted by water, right? So anything which we call as fecal-oral transmission, something like cholera, something like food poisoning, is water-borne. Water-based diseases means that the intermediate host is around the water. For example, cyclops. So can I say guinea worm? Yeah. Or dilatum are all water-based diseases. Water-washed diseases means diseases which will be washed if you take a bath, right? For example, scabies, trachoma are water-washed diseases, and water-related are all of your vector-borne. Vector-borne meaning all diseases around mosquito will be water-related. So malaria, chikungunya, dengue. So a little confusing, but pretty simple list you want to remember. 4 more instruments for air now. So this is what is your kata thermometer. In Hindi, you want to remember a mnemonic, lal kutte ne kata, means what? Red. So this is red in color. Kata, why kata? Because your velocity was low. So this measures low air velocity. And what did we say? If the dog bites you, what are you going to do? Wash it, right? You are going to cool the wound. So cooling power of air. So this measures the cooling power of air. Better answer, low air velocity. What you see here looking like a globe is a globe thermometer, and this is what is going to measure the effective temperature because of the air. This is looking like a sling, right, which you do like this. So this is sling psychrometer, and this is going to measure the humidity. What you see here is called as an anemometer, and this is going to measure the wind velocity. Okay, so these are the things, these are the instruments from environment. More one-liner questions. So this is just a page of miscellaneous stuff. The rest of this video is all miscellaneous one-liners I've collected from all repeat questions. So just read this again and again, right? So water collection during outbreak, this is last to last AIMS question. So this is how you take water. It's a gentle stream to avoid splashing. Okay, don't find more meaning into it. This is how you have to collect water, gentle stream. This has not been asked, so I'll take a party if this does come. There is something called as Langmuir saturation index, which includes 4 things in water: alkalinity, pH, hardness, and TDS. TDS is not tax deducted at source, it is total dissolved solutes. Okay, so this is what is Langmuir saturation index, total dissolved solids, right? So this is what is Langmuir saturation index. For air pollution indicators, the best indicator, remember, is sulfur dioxide, but 3 S's: sulfur dioxide, smoke, and suspended particles. So this is the basis of our air quality standards. Okay, so 8 things are needed. So this is not there, so you can just add this. So PM 2.5, PM 10. They can give you PM 5 as an option, that's not included. Okay, so PM is particulate matter. You have CO, you have NO2, SO2 obviously is most important. You have ozone, ammonia, and lead. These are the 8 things we measure for our air quality indicator. And this is the grading, and they had asked how is it around Diwali in Delhi. If it shows 400 to 500, and that is what it usually does, this is severe. So you have good, satisfactory, moderate, poor, very poor, and severe. So just remember these numbers, and they are just 0 to 50, 50 to 100, and then 100, 100. You keep increasing. So this is what we need to remember. Secondary air pollutant is referred to as ground level ozone, and that's what we are measuring as well. The best biological indicator is considered to be lichen. 2 indices, soiling and grit. Soiling index, SIR, is for smoke, whereas grit index is for dust. Okay, and maximum greenhouse effect, this is water vapor. All of this while we are trying to reduce CO2 emissions, while PSM says it's water vapor. So water vapor more than CO2. Temporary sewage disposal. So let's say you went camping. So what is the method of disposal of sewage for temporary methods? It's burial. Okay, bury the waste, it's the best. So that is what is best. Area per 10k population for sanitary landfill is 1 acre. Just remember this, 1 acre for 10k population. Per capita space in a house should be more than 80 square feet to prevent overcrowding. And the criteria for a proper house is that the doors and the windows should occupy more than 2/5 of the space, of the floor space. Okay, so that is what is said. Light, now there are 3 units which AIMS had once tested. So luminous intensity is candela. Candle gives you intense light. Flux is lumen and illuminance is lux. So this becomes our cross mnemonic. Okay, cross mnemonic is an unexpected place. So lux is lum and lum is lux is how you will remember. Another miscellaneous box now. So according to WHO, the proposed spending on healthcare sector should be more than 5% of the GDP. Okay. Right to life is Article 21. Concurrent list of Indian Constitution is food adulteration. So this concurrent list includes food adulteration as a part. So these are all just random one-liner questions I've collected from over the years. Study of disease and social conditions is referred to as social pathology. This definition has been asked a lot of times. Now for measuring protein quality, there are various parameters. So I'll give you 3 answers here. Depending on this order, you can mark whatever is there in the option. So if Dias is in the option, that's the best. So this is Dias more than PDCAS more than NPU. What do these terms mean? So DIAAS is the digestibility indispensable amino acid score. Okay, so digestible indispensable amino acid score. PDCAS, you might have guessed, amino acid score. PDC is protein digestibility corrected amino acid score, and NPU is the net protein utilization. So don't be scared, just see this once, all right. These are 3 measures of protein quality in this order. For WHO, 7th April, World Health Day for this year, the motto was My Health, My Right. And to indicate that vitamin A deficiency is a public problem, Bitot spots prevalence more than 0.5% indicates that vitamin A deficiency is a public health program. Is a public health problem. So these are few random one-liners. More miscellaneous stuff. So first of all, talking about a little maternal child health care. So there are 3 things. One is essential obstetric newborn care, one is basic, one is comprehensive. Essential is something that should be available at a PHC. Basic is something that should be available at a CHC. And comprehensive is something which should be available at district hospital. So at a PHC, you want registration, ANC, delivery. Delivery can also be done at PHC and newborn care. Then basic will include what all? Antibiotics, oxytocin drugs, matlab oxytocin, anticonvulsants, manual removal of placenta, manual vacuum aspiration of RPOC, vacuum extraction and newborn resuscitation. Whereas district is where you should ideally have cesarean section and blood transfusion. So these are according to government. You can just remember this. ANC visits, ideal by WHO. So here it's a little tricky. Remember first, minimum by Government of India is 4. Minimum by Government of India is 4. Ideal by Government of India is 13 and ideal by WHO is 13 and minimum by WHO is 8. So this is the updated value that I am teaching you. Okay, it's slightly different from what I taught last time. So this is what the update is, that minimum as per both government and WHO, you want to remember 4 plus 8. 4 plus 8 equals 12, very close to 13. So you want to remember ideal for both of them are going to be 13. Okay, so minimum 4 and 8 and ideal becomes 13. Now, we have this ASHA program wherein we give incentive to ASHA for home-based newborn care. Okay, so the ASHA is going to come for home-based newborn care for how many times? So if the delivery is a home delivery, there is a day 0 visit also. Apart from that, the visits are going to be 3, 7, 14, 21, 28 and 42. Upon completing the 42nd day visit, the ASHA gets the incentive here. Whereas in institutional, the 0-day visit can be skipped. So essentially 1, 2, 3, 4, 5, 6. 6 visits for institutional, 7 visits for home delivery. So this is what you want to remember. And there is also now a young child assessment where the ASHA has to go for assessing young child as well. So this is home-based newborn care. Now talking a little bit about tip of iceberg concept. The tip of iceberg concept tells us that for all diseases, what we actually see in our hospitals is the tip. What we are not seeing are the invisible cases, which are asymptomatic carriers. This concept does not apply to what all is the question. So it doesn't apply to MTR. It does not apply to measles. It doesn't apply to tetanus and it doesn't apply to rabies. Rubella, a little controversial. So look at the options and then decide. Rubella may be an answer if the 4th option is something out of this list. But if the other 3 options are this, don't include rubella. Okay, so rubella, just terms and conditions apply. Health education in one box, talk series by experts with Q&A. So one by one, if people keep coming and teaching you, that is what we call as a symposium. But if all of these experts are sitting and you are interacting with audience with Q&A, this is called panel discussion. 6 to 12 people discussing in a group is called focused group discussion. Very important, right? So this is more done in like MBA, etc. Focused group discussion. Practical skills teaching, this is called workshop. For example, if I keep a workshop and I teach you how to do ultrasound, right, that is called a workshop. Whereas step-by-step enactment, right, community you teach how to make ORS step-by-step, that is called a demonstration. There is another method called Delphi method. So Delphi method is where first you give an anonymous questionnaire, okay, to all experts. So an anonymous questionnaire is sent to the experts and all of the data is then analyzed. Okay, so then you analyze the data and that is called as a Delphi method, and then you can go back to those experts and ask them targeted questions. So just remember something about questionnaire from experts, that's Delphi method. So these are your health education methods. Lots of miscellaneous stuff on this page. Kuppuswamy index, this is for urban, right? So this is for urban index. Three things, vowels stick together. Three factors, income, occupation and education of the head of family is included in Kuppuswamy index. The range is from 3 to 29. 3 is minimum, 29 is maximum. So this is your urban stratifying scale. Few bodies and what they do. Ford Foundation is helping in building toilets in rural India. This is a repeat question. SIDA is funding the TB program. You can remember, if you are in India, you will get SIDA TB. Danida sounds like Danda. Who will need Danda to walk? That is blindness. So this is your national blindness program, more of which we will talk about in Ophthal. Colombo program, last year INICET question, CO is CO. This is helping build cobalt units. Cobalt 60 is what we use for radiotherapy. So Colombo is cobalt. Applied nutrition program is helping give manures to farmer, right? So manure and pesticides to farmers, and this is gonna come under UNICEF. So this applied nutrition program is funded by UNICEF. 3 targets. So the MMR target is less than 70 maternal deaths per 1 lakh live births, right? So that's the target. For NMR, it is less than 12 per 1000 live births, and under 5 less than 25 per 1000 live births, right? So less than 12, less than 25. So remember 3 numbers, 12, 25, 70. These are your sustainable developmental goal targets. So 3 targets under sustainable developmental goal. This has been asked, okay, MMR. Then you want to remember this one line, infectious disease is a conditioning factor for malnutrition. So this is asked as a one-liner. RDA is defined as the dietary requirement that meets the requirement of 97% population. Again a one-liner. Talking a little bit about non-communicable diseases. So we follow what is called as rule of halves. What that means, I'm sure you have heard of this, that half of the entire population have hypertension. Out of this, half of the people know, means they are diagnosed. Out of these, half are taking treatment, and out of these, only half are getting adequate treatment. Pretty scary law, but this is what the law of halves says. Tracking is also for hypertension. So they say that if your BP is high as a young child, it will track on the higher side and vice versa. So this is tracking. Monica is essentially monitoring in non-communicable diseases. So this is a monitoring program also for your non-communicable diseases. For non-communicable diseases, there are WHO steps. There are 3 things. It includes verbal, which is the history. It includes physical, which includes the measurements, and biochemical, which includes the tests, right? So 3 components are included here. The cafeteria or gather approach are for contraceptives, okay? So these are for contraceptives, cafeteria or gather approach. You also want to remember the DASH diet. This DASH diet is for hypertension, which includes 3 things, 3 measures to control hypertension. One is exercise. So they advise physical activity or exercise for at least 30 minutes a day for 5 days a week. Second, a low salt diet, and third is saturated fat should be less than 10%. Saturated fat should be less than 10%, whereas salt intake should be less than 5 grams a day. So these are 3 things that you want to know about. Next, we do questions about disaster. So what is it called when you are decreasing the impact of a disaster? This is called as mitigation. Okay, so this has been asked as a one-liner. Impact reduction, mitigation. Most common disease associated with disaster, it's going to be gastroenteritis. Most common vitamin deficiency is vitamin A deficiency. Most common zoonotic disease you want to remember here is going to be leptospirosis. I feel question can be asked from here, what all vaccines should be given. So two most important vaccines would be Hep B and diphtheria or tetanus toxoid. Okay. Apart from that, we can also give cholera as well as typhoid vaccines. Okay. So 4 vaccines. If asked to choose the first 2. Only vaccine which can be given in outbreak is measles. What this means, I have explained in micro as well. It means that if there is a measles outbreak, you can give a measles vaccine because that's the only vaccine whose incubation period is shorter than that of the disease. In any other disease, the disease is going to spread faster than your vaccine anyways, right? So that's what it means. The most crucial preliminary step is chlorination that will help, and the nodal ministry is Ministry of Home Affairs, right? So that is what controls disaster. So you have gotten a lot of questions from disaster management. What else? Now 3 terms. So here what you need to remember is difference between opinion, belief, attitude. Opinion is something which is temporary and subjective, right? An opinion can keep changing, and it's something which is based on what I think, right? So opinion is the worst. It's temporary and subjective. Whereas belief is something that is permanent and again subjective. So a belief system, I believe that politicians are good. That is something which is subjective based on my own personal experiences, but it's permanent. That will not most likely change. Whereas attitude is permanent and objective, So this is what these things are. So attitude and beliefs don't change. Belief is subjective, whereas attitude is objective. Then health management chapter in one box, cost benefit analysis. Any project, if we say that this is the monetary benefit, for example, I launch a program to eliminate TB. And I say that this will save the government of 5 crores of health expenditure of the patients. This is cost benefit. Cost effectiveness analysis, as we said, is measured in terms of QALY. How many quality adjusted life years are you adding to the population by doing this program? Network analysis includes 2 things. Program management review technique, where you include all of the steps in a stepwise manner, and critical path method is the longest method out of these. Okay, so let's say I'm starting a new project. Okay, there are many things which need to be done. One includes the cement and plastering of the building, one includes furniture, one includes wiring. So what should I start with? I should start with what is going to take longest, and you do everything simultaneously. So that is the critical path method. You start with it the first. What you see, this is an INICET question. This is what is called as a sufficient causation method. Okay. So this is sufficient causation method basically, or sufficient causation model. Basically, for any disease, there are sufficient factors and there is a necessary factor. Necessary factor means something, let's say TB. We are talking about TB. So Mycobacterium TB is necessary, and sufficient causation means what are the other factors? Absence of BCG, ventilation, nutrition, crowding. These will be the other causes. Okay, so this is what is sufficient causation model. Next, we talk about 2 things, components of PHC and elements of PHC. Components of PHC are 4. This has high chances of getting asked. So, one is community participation, like having ASHA, who is a part of community, participate in the healthcare of the community. Intersectoral coordination, where different departments will work with one another. Appropriate technology, like you monitor the outcomes, and equitable distribution. So, everybody has equal accountability, right? So these are 4 components. You essentially have to remember these words. Elements of PHC you can remember from elements itself. E for education, L for prevention of local endemic diseases, E for essential drug availability, M for maternal and child, E make it as I, immunization, nutrition, treatment, and water and sanitation. So this is like core memorization stuff. Just go through this one more time. These are elements, these are components. Health planning, this is the cycle of health planning. So for any health planning to start, first we need to analyze the situation. This you can correlate with how you will prepare for your exam. The first thing is analyze where you are currently at. What's your baseline score? What was your last NEET score? Where did you go wrong? And then set out your objective and goals. For that you will ask me, ma'am, what does it mean? What is goal? What is objective? What is target? Goal is something which is your long-term desired state. It is not measurable. For example, your goal should be in life to become a good doctor. This is your goal. This is not something which can be measured. So, goal is usually non-measurable. Objective and target. Objective is the measurable goal that you have, which means I want this rank. I need a rank under 1000. That's your objective. For that, you have to set short-term targets that by November end, I need to reach a score of at least 130. By December, 140. I keep increasing that by +2 in every GT I go, and eventually before NEET, I'm at a score of 150 to 160. So these are your short-term measurable targets to get to the eventual objective. So this is GOT, goal, objective, target. So you set out your objective, your goal, your target, and then you assess, okay, I have BTR, I have this other app, I have this QBank, this is all I have. Then you set your priorities that, okay, first I have to watch this BTR video, I have to annotate it, and then I will do PYQs, then I'll do custom module, I find out lacunae, and then I'll see the main notes of that or video if needed. So this is your priority, your plan. You formulated a plan. Most important is implementation, right? Yahan tak we all do. This is where we all fail, which is implementing it. Then you constantly keep monitoring it that, okay, am I doing this? I keep coming to you with an END, which you guys don't give. So ENDs, are you attempting the ENDs? Are you getting a good score? And we evaluate how we are doing. So this is what is the health planning cycle. Another box, essential healthcare has 4 A's. Available, it should be available. It should be accessible. It should be affordable, acceptable. So these are the 4 A's. They'll give you some random 4th A and ask this as all except. 2 acts, both of which come under Ministry of Labour. First one is the Factory Act. Both of these were passed in 1948. Okay. So Factory Act is not applicable to 4 places: DMRE, Defence, Mining, Railway and Eateries. ESI Act out of these is not applicable to DMR, Defence, Mining, Railway. So this is sorted. Come back to factories. This is asked in this year FMG only. The per capita space for every worker should be more than 500 cubic feet. 1 safety officer per 1000 worker. Are age less than 14-year kids allowed to work? No. What about 14 to 18? They are, but only during daylight, right? So 6 AM to 7 PM, maximum 4.5 hours per day. What about older people? So 48 hours per week is the maximum, or less than 9 hours, even with overtime, less than 60 hours per week. Imagine telling this to a doctor. Okay, they will say, I'm working 48 hours in one day. What are you saying, 1 week? Okay, so this is what is Factory Act. Under Factory Act, 29 disease come under notifiable disease, and most commonly asked question, bagasosis is not a part here. Going to ESI Act. So ESI Act, you want to remember, doesn't apply to DMR, right? So Defence, Mining and Railway doesn't apply. Here, this is contributed 0.75% by employee and 3.25% by the employer. Sickness benefit. So this is the amount that is paid if you are sick. So 70% of your wage will be paid to you for a period of 91 days. Whereas for a certain diseases, 80% of your pay will be given for 2 years. This is a group of around 34 diseases for which you give. Enhanced sickness benefit, when remember genitals being enhanced. So this is vasectomy or tubectomy. So vasectomy or tubectomy, 100% of your wage. So in vasectomy, it's for 7 days, whereas tubectomy, it's 14 days. Mat leave, maternity benefit is 100% of your wage for 6 months. You also want to remember it's 100% for 4 weeks if there is an MTP, or it's 100% for 6 weeks for MTP, and it's 4 weeks for any pregnancy associated disease, right? So 6 months, 6 week for MTP, 4 week for pregnancy disease, and funeral benefit is 15,000 given to if somebody dies, right? So if the person working dies. So this is 15,000. So these are the numbers from these two pages. Next, these are committees which don't exist anymore, but they can still ask you this. So just go through this very superficially. So Bohr committee is the one which established that primary healthcare centers should be 1 in 40,000. They gave the 3 million plan and they said anybody who study PSM for 3 months should be called as social physician. So we are all social physicians, if not anything else. Then All India Health Service, this is the Mudaliar committee. Then you had Chadda committee who mixed everything. They said that we will have one basic health worker per 10,000 population who will look at everything: malaria, vital stats and family planning. Then somebody intelligent called Mukherjee came and said that you can't do this. At least de-link family planning from malaria. Okay. Then you had somebody called Jangalwala committee. They said that don't work like a jungle. You should have equal pay for equal work, special pay for special work and no private practice. Then you had Kartar Singh, you can remember, who works. Kaun karta hai is multipurpose worker. So multipurpose worker established and there were health supervisors for 4 multipurpose health workers, and PHC they then said that make it 1 in 50,000. Then you have Srivastava committee where you have all R's like Srivastava, where they created this new cadre of semi and para professional workers, referral services, research-oriented medical education and rural health scheme in 3 tier like Panchayat and Gram Panchayat was established. Urban revamping scheme was Krishnan. National medical healthcare policy is Bajaj. And the last one which is the only one that has been asked in the recent times is universal health coverage was by expert level group. Okay, so this is something which is not very important. Just go through this once. Now let's talk about healthcare delivery in India. So here you need to know all of the workers. So Asha, Anganwadi worker, trained birth assistant and village health guide. These 4 are what we call as our grassroots workers because they are at a village level. The norm that you need to remember. So the norm for Asha is 1 in 1,000, but now the proposed is make it 2 per 1,000 because we have met this criteria. Anganwadi worker is at an Anganwadi center whose population norm is 1 in 400 to 800, whereas trained birth assistant and village health guide are at village level 1 in 1,000. So this is the population norm. Then their education qualification. So Asha should be a 10th pass person. Anganwadi worker also 10th pass. For trained birth assistant or DAI, there are no such educational qualifications. She only knows how to deliver. And for village health guide, it is 6th pass. While we are talking about this, let's go to further. So multipurpose worker, male and female, where are they? They are present at a sub-center level. So we will see the population norm soon. And health assistant and health visitor are at PHC level. And Usha is your Asha of urban settings. So Usha is for in urban setting, 1 Usha per 200 to 500 house or 1,000 to 2,500 population. So very similar to our original Asha. Okay. So forget about these two now. Now focus on these. Okay. So multi-purpose worker, male and female, now because they are at a higher level, they should be 12th pass. So 10th, 6th and 12th, 12th. Right. So this is the educational qualification. Now coming to that training period. So very important, Asha is somebody who is trained for 23 days. So Asha is 10th pass and she is trained by Anganwadi worker. Okay. So Asha ka training is done by this who is your Anganwadi worker. Anganwadi worker has to undergo a training for 4 months and she reports to Mukhya Sevika. Okay, her training protocol is what is called as Odisha training. Whereas Asha's training as well as multipurpose workers training module is called Dakshata. These are just recent updates. Odisha for Anganwadi and Dakshata for Asha and multipurpose workers. Trained birth assistant training is for 1 month. She is trained by multi-purpose worker female. So this one, ANM, is going to train in delivery for 1 month. Village health guide is trained for 3 months, right? So this is what you want to know. And both multi-purpose worker, because they're at a higher position, undergo training for 1 year under Dakshata module. So least amount is for Asha. 23 days by Anganwadi, 4 months for Anganwadi, 1 plus 3 equals 4. That's how we will remember this, and 1 year for multi-purpose workers. Now let's talk about the other things of Asha. So Asha should be present from the community. She should be a 25 to 45-year-old female who is either married, divorced, or a widow. She is selected by the village panchayat of the same village. So this is what is community participation example, right? Training is done. What's her job? So she is the main mobilizer. She is the one who creates awareness and brings the patient to the hospital. So she is also responsible for making toilets, and we saw various incentives, one of which was Janani Suraksha Yojana for institutional delivery. She is also the depot. She is the carrier of ORS, antibiotics, iron folate, and family planning services. She can also give dots. What she can't do is vaccine. Obviously, she's been trained for 23 days. You can't, right? You have been training for 5 years. Even some of you can't give a vaccine, okay? No offense, but she can't. So she can't give a vaccine. She obviously can't conduct a delivery. So these she will not do. Impact indicator is IMR, okay? So this is what you need to remember. Is the main indicator is how much is the infant mortality rate reduction. So this is what is Asha. Anganwadi is done. Trained birth assistant is DAI, 1 month training. Multipurpose worker trains her. Village health guide overall educates. Multipurpose worker, very important. They are at the sub-center level. Male has 3 special functions. They are the ones for active surveillance of malaria, for active surveillance of TB and sputum collection, and water chlorination, whereas female has ANC registration, delivery, and vaccine. So more mother and child are with female, right? So this is very, very important slide. Lastly, what we want to do are the healthcare norms in India. So population norms. So rural and urban both I'll be teaching you. So sub-center, now they are starting to be called as health and wellness care centers. A matlab no delivery, B matlab delivery is happening. Swasthya Chowki is the urban counterpart of sub-center. PHC A and B, A means less than 20 delivery per month and B is more than 20 delivery per month. And this is what you need to know is responsible for school health. You have urban PHC, community health care. Community health center is your first referral unit. First referral unit, you want to know the criteria is they should have a 24-hour blood bank with obstetric and pediatric care, which is available round the clock. So that is what is first referral unit. So a lot of PHCs can also be upgraded to FRU if they fulfill this criteria. So that is what you want to know. Otherwise, FRU is CHC means anybody from sub-center and PHC will be referred to a CHC, and you have urban CHCs here. So now let's do the population norms. First of all, sub-center. This hilly and plain differentiation is only for rural, not for urban, okay? So this is what is 1 in 3,000 and 1 in 5,000. Sub-center and sub-center usually will have 3 beds. Then make 5,000 into double. So for urban, this becomes 1 in 10,000 population. From this only go to 20 and 30K. So PHC is 1 in 20K and in plains it is 1 in 30K. And PHC is usually a 5-bedded hospital. Add these two numbers, urban PHC norm becomes 1 in 50K, right? So this is how you have to remember together. 3,000, 5,000, iska double becomes 10, 10 ka double becomes 20, 20 plus 30 leads to 50. So this is what you will remember. Now coming to CHC. So CHC you will remember is 1 in 80K for hilly and 1 in 1.2 lakh for plains. A CHC will usually have 30 to 50 beds, okay, 30 to 50 beds. The question actually has come only from here. What about urban CHC? So urban CHC you want to remember is 1 in 2.5 lakh population, but in metro it will be 1 in 5 lakh because you have more hospitals, you know, private hospitals as well in a metro, so government doesn't need to contribute so much. In urban CHC, the hospital is usually 50 bedded, whereas your metro should be 100 bedded. So this is how you have to remember. This is core choti copy. You have to revise this again and again. As we discussed, this village health sanitation and nutrition committee is the panchayat, and who is the part of it is Asha. Okay, even Anganwadi worker can be a part of it, but Asha is the main person. School health, as we said, PHC is responsible. Few numbers: minimum area of 10 square feet per child, less than 40 students per classroom, and the desk type should be minus. Minus means that if this is the chair and this is the chair should be inside the desk so that it's comfortable to write. One urinal per 60 students, and for vision, very important, one teacher will check one teacher per 150 kids. Any child whose vision is less than 6/9 refer to PHC because that's responsible for school health. Last table is the population norms, again like core BTR stuff. One doctor per 1000 population, one nurse per 5000 population. 10,000 are two, one lab tech and pharmacist, so lab technologist and pharmacist, 2 for 25,000. Malaria microscope we have done, and set is for leprosy. Okay, set are your survey, education and training centers for leprosy, 25,000. TB microscope for 1 lakh. TB unit we had already done is 5 lakh, so that was a range, right, 2.5 to 5, and STLS is also there in TB unit, so that's understood. This is important, one ophthalmologist per 5 lakh or per 5 CHC, one ophthalmologist should be there. So with this we mark the end of PSM.